हाँ
आपको लिंक दिया था ना फिर आपका।
हाँ, लिंक पे मैं जा रहा हूँ, लिंक पे मैं जा रहा हूँ। हाँ हाँ हाँ,
लाइव है सर आप।
ओके ओके। Hello, welcome students, welcome from where we are streaming. There would be a slight lag of, yes, I think, okay, we are live, yes. Hello Samir, yes, yes, okay, yes, test and better, absolutely. Okay, yes, medicos will, no, it's starting now, okay. Can all of you hear me? Can you just type in the chat box so that I know that I'm visible to all and audible to all of you. We are live, yes. Yes. Okay. Dhanya Mary. Yes. I'm Prabhakaran. Yes. Okay. All of you. Super. Okay. So I'm Dr. Punit Bhojani. Good evening, everybody. Good afternoon. So the plan of action is, yes, welcome all of you for the upcoming FMGE rapid revision from where we are streaming. There would be some lag of some few seconds. So just wanted to, yes. Good evening, all of you. Superb. Okay. Yes. So welcome all of you to this OBGY rapid revision session, and we are going to discuss some of the important MCQs. Yeah, but a PDF also, Gokul, you will get. We'll get the PDF as soon as the streaming is over. Okay. Yes, surely. Yes. So we are going to have some very important MCQs. I'm Dr. Punit Bhojani, and trust me, whichever I will be teaching you, there will be a lag of 10 seconds is expected, but a 5 seconds lag, but the audio video all clear, right? Yes. So please pay attention, all of you. This is a MVP. That means what? Must know MCQs. Okay, whichever may be your exam specifically for the FMGE upcoming examinations, these are the must know MCQs I'm going to discuss. V is virgin MCQs. Okay, virgin MCQ is a term coined by me, which means MCQs not asked till now in the entrance but will come in the future for sure. Is coined by me as virgin MCQ, and of course P is the previous year's MCQ or the PYQ. Okay, so all of you are going to enjoy this. It's 4 hours streaming, 4 to 8 p.m. MVQ, most important high yield MCQ. V is the virgin MCQ, MVP, and P is the previous year's MCQ. Okay, so what is the plan of action is that I will be flashing some of the questions, and we, all of you, please type in the chat box. Right, wrong does not matter. Yes. Yes, but ऐसे ही पढ़ाएंगे. We'll try our best. Medico will try our best so that everything what we asked, touchwood till now, it's a record that whatever we are asking, that is only coming in the entrance paper. So we'll try to cover all different kinds of MCQ, and I will be covering all the 3 types of MCQ. Will be covering one-liners, clinical cases also we will be covering, and of course images also we will try to cover. Okay, somebody asked me the time. Yes, 4 p.m. to 8 p.m. Is the session. So we hope that all of you have a great time and enjoy. Just last thing before I begin, this is my, because many students asked me that, sir, can I have your Telegram channel and can I have your YouTube link also? So this is my channel. I want all of you to have a quick screenshot. Please have a screenshot of this image so that you can subscribe to my YouTube channel. And yeah, thank you Faraz, SRK, superb, congratulations. Okay, so just a request, all of you quickly have a photograph of this image, where this is my YouTube channel and my Telegram. All of you can post your doubts also over there on Telegram, so that even after the session is over we can be in touch. And all of you do subscribe to my YouTube channel for many such interesting videos and lots of this. Yes, Kawana, absolutely, for NEET PG also, because today the difference between FMG NEET PG very minimal. Today FMG is getting NEET PG like MCQs. Okay, so Kawana, it is also for NEET PG, not only for FMG, but main the target because it is this. Yes. And yes, definitely Meet Patel sub concepts, everything you will love it, everything we are going to discuss. So let us begin. Welcome to the stream, all of you. I hope all of you have captured a screenshot of this. This is my YouTube channel and the Telegram channel, and I want all of you to please subscribe to the YouTube channel and the Telegram after our sessions are over, or even during the session. All of you can do that. So let us begin the most important virgin and the PYQ MCQs, most important MCQs for any exam. V is virgin MCQ coined by me, my specialty, never asked till now but will come in the future. And P is the previous year's question. Okay. And one announcement that this NLC coaching class Next Learning Center from 15th of January, they are starting a new batch in Delhi. Okay. So all of you, those who are in Delhi, 15th January onwards, a new batch is starting and you may want to enroll. Okay. So let us begin our discussion, and I want all of you first MCQ. All of you read the question and then let us start. A girl is brought to the OPD with the only complaint that the menarche is not yet attained. Okay, so which of the following indicates primary amenorrhea? Okay, flood the chat box with the answer. Okay, yeah, Samir, we'll go as fast as possible. Please answer the first MCQ. Okay, D, anybody? Akib Bhagwan has given D as the answer. Akib Bhagwan has given D as the answer. I want all of you to participate. Please participate. Right, wrong does not matter. Whether we are right or wrong does not matter. Okay, we are here to all learn from our mistakes. So even if you make a mistake over here, it is okay. Okay, now A, B, C, D. Okay. Okay. Yes, so this is a total confusion. And why have I selected this? Because all of you clap if you feel happy. Clap if you feel happy. The definition, yes, okay. So not A, not D. D was the old answer. Please, all of you make a note. This was the answer. Now that is not the answer. Okay, so now all of you please pay attention. Very, very important. Okay, all of you please pay attention. Thelarchy, the sequence of events for everybody, for all females, thelarchy, pubarchy, menarchy. That means first there is going to be development of breast development, then axillary pubic hair development. This is the axillary and pubic hair. And then the menses are going to start. Is this understood to all of you? Now, why this? So this presence of thelarchy and pubarchy, in short, is called as secondary sexual characters. Okay, it's going to be a secondary sexual characters. Okay, now can anybody tell me what was the old definition? So remember students, the old definition for our primary amenorrhea was 14 years and 16 years. 14 years and 16 years. Is this understood to all of you? 14 years and 16 years was the old, okay, old definition. I'm writing. So what is the definition is that, sir, if I see a girl in the OPD, and the secondary sexual characters are not there only, when the girl used to reach 14 years of age and there is absence of secondary sexual character, that means there is no hair, no axillary pubic hair, no breast development, we used to call it as primary amenorrhea. But if the secondary sexual characters are present, then we can wait. Like how in that Karan Arjun movie, Rakhi was waiting कि मेरे Karan Arjun आएंगे. वैसा here also we can wait कि मेरा menses आएगा. मेरा मतलब the patient menses will come, and then you wait till 16 years of age. So 14 and 16 was the answer. Now this has been decreased by one year, and 14 has become 13 years and 16 has now become 15 years. I hope all of you clap if you have learned something new, and all thumbs up in the chat box. Flood OG Guru in the chat box if you are loving this. Okay, so 13 and 15 is the new criteria, and therefore 100% this MCQ is coming in the entrance exam. The definition has very rarely changed. 14 has now become 13 and 16 has now become 15. So just look at it. Okay. Yes, so just look at it, and so we have to choose. And 13-year-old, no menses but with breast development. Will I call this patient? No, beta Samir. With breast development, I will wait. Isn't it? In this patient, I will wait for some time more. So this is not the answer. Yes, very good. 13-year-old, no menses without breast development. option number C becomes the answer. Okay, option number C becomes the answer, and all those who had said the all those who had said 30 C is absolutely correct, even if I got wrong. So I repeat, option number B is why not the answer, because a breast development is already present. So in this patient, I will wait. I will wait till 15 years of age. I will wait till 15 years of age. Yes, so all of you correct. And 13-year-old, no menses without breast development. So this is surely coming. 14 was the old answer. Now it is wrong. Okay, so I hope all of you get this correct for sure in the exam. Let us go on to the next MCQ without wasting any further time. Again, a previous year. Infertility is defined as inability to conceive after. Okay, many of the students make a mistake and they directly mark the answer as option number A. Okay, infertility is defined as not able to conceive after 1 year of marriage. How many want to go with option A? How many want to go with option A? Anybody? Infertility is defined as not able to conceive after 1 year of. Okay, C. Yes, all of you, super. Elizabeth, I cannot take all them. Excellent, all of you, all one. Okay, absolutely correct. This is a mistake which many students make. Please understand, it is not 1 year of marriage. Okay, marriage since is not important. Okay, marriage is important, but in the definition of infertility, marriage since is not important. Why? Because sir, if the couple is married for 2 years, 3 years, but if the husband is using condoms, or if the wife is using birth control pills, then that is not infertility. Or similarly, if the husband is in India, wife is in America, then that is again not infertility. Okay, so 1 year criteria is correct for all of you, but 1 year of regular unprotected intercourse. This looks very simple, but this has been asked in the previous year, and that's why I'm doing this question, that 1 year of regular unprotected intercourse. Now, can anybody quickly tell me what is primary infertility and what is secondary infertility? What is primary infertility? Okay, anybody? What is primary infertility? Means that the patient has never conceived in her life. Okay, patient has never conceived. Okay, never conceived in her life at all till now. That is the meaning of primary infertility. And secondary infertility means, sir, the patient has conceived once. Patient has conceived once in her life. Conceived once, but now she is not able to conceive. Okay, now, okay, patient has conceived once, but now she is not able to conceive. Okay, now not able to conceive again. So if she has conceived once in her life, whatever maybe, that could have been live baby, dead baby, she could have opted for MTP, and then now she is not able to conceive. That is called as secondary infertility. Somebody asked me, the Dr. SS, no, secondary amenorrhea definition beta is the same, there's no change. Anybody, what is secondary amenorrhea definition? Absence of menses for 6 consecutive months. Okay, absence of menses for 6 consecutive months was again the old definition. Secondary amenorrhea, somebody asked me the definition in the chat box. Secondary amenorrhea, absence of menses for 6 consecutive months, has now been changed for 3 months. Absence of menses for okay, 3 months. If the 3 consecutive months the patient has not got her periods, you call it as secondary amenorrhea. And can anybody in the chat box tell me what is the most common cause of secondary amenorrhea? Most common cause of secondary amenorrhea. Absence of menses for 3 consecutive months. Yes, Dr. AM, correct. 3 months, no menses. Very good. And I want the answer, most common cause for secondary amenorrhea. No, not Ashaman. Very good. Yes, all of you correct. All of you correct. Pregnancy is the most common cause. Pregnancy is the most common cause for secondary amenorrhea. Please keep this in mind. Very, very important MCQ. But a PCOD is, yes, second most common after pregnancy. Okay, after pregnancy, then an ovulation, PCOD is also very common, but pregnancy is more common than PCOS. Okay, so no, Dr. PK Turner is primary. Okay, is it clear to all of you? Yes. So now moving on to this, everything should be clear in this. Yes, commonest cause of primary amenorrhea is, anybody, what is the commonest cause of primary amenorrhea? Androgen. We have got 4 options, and clap if you will feel happy with one MCQ. I am going to discuss 3 other MCQs also. Okay, 3 other MCQs also. The commonest cause for primary amenorrhea is, yeah, but Anita Parvin, primary amenorrhea, we discussed already what is the definition and all that. No, all those saying number 3, all those telling me number 3 is wrong. Mullerian agenesis, also called as RMKH syndrome, what it is? This is the second most common cause. This is the second most common cause of primary amenorrhea. Please don't make a mistake. This is no, all those saying option number 3 is wrong. Option number 3 is wrong. Yes, Akib Bhagwan, very good. Humayun Farooq, very good. And yes, adorable vibes, very good. So ovarian dysgenesis, because ovarian, so see how the name changes, all of you are getting confused. Don't get confused. Ovarian dysgenesis, another name is Turner's syndrome. Okay. Okay, ovarian dysgenesis or Turner's syndrome. Turner's syndrome, what all of you know as, karyotyping also will discuss. Ovarian dysgenesis or Turner's syndrome is the most common cause for primary amenorrhea. Is this understood to all of you? Yes, Ramya, Divya, Pankaj, the crackers, all of it. Okay, so Turner's syndrome number 1, our Mullerian agenesis is the second most common cause, and androgen insensitivity syndrome, also called as what, anybody, what's the another name for androgen insensitivity? Testicular feminization syndrome, TFS. This is the third most common cause. Okay, that is the third most common cause for primary amenorrhea. Okay, so clap if you feel happy with one MCQ. I have discussed 3 MCQ. Okay, so every MCQ we're going to discuss many more MCQs. Is this understood to all of you? So Turner's syndrome or ovarian dysgenesis is the most common cause of primary amenorrhea. The androgen insensitivity is the third most common cause, and Mullerian agenesis or RMKH is the second most common cause. Okay, yes. So all this MCQs, also the PPT, the PDF, I'll send them, and then you can download it after our this streaming is over. Okay, yes, all of you. And karyotyping we are going to do for all of them, which is very important. So don't make a mistake in those. Okay, now anybody can quickly, somebody tell me. Yes, androgen insensitivity. What is the problem? What is the problem in this testicular feminization syndrome, or as the name suggests, androgen in? Yes, hypothyroidism base. Very good. Aragdeep Adhikari, Aragdeep. Yes, the thyroid disorders can cause secondary amenorrhea. But remember, thyroid disorders is also going to cause menorrhagia. Okay, so thyroid is very funny. All of you keep in mind, thyroid is very funny. Thyroid can cause menorrhagia also. Thyroid can cause amenorrhea also. Okay, yeah, so better notes will, so very soon the app will also become, I'll telling you about this A for Apple. Right now you can just subscribe to the Telegram channel and the YouTube channel. I have sent the screenshot, I have sent the barcode at the beginning, and after some time also I'll be again flashing in some time, so that all of you can at least join this, and very soon all the books and all that also will be giving the notification about the notes and this. Yes. Okay. Yes. So the problem over here is that there is a receptor level problem. Receptors are, as the name suggests, there is insensitivity. So that's a receptor level problem, and androgen is present. It is not absence of testosterone, but the testosterone is useless. Nikamma testosterone. Nikamma testosterone. Testosterone is secreted, but testosterone cannot do any work. Okay. Yes. Karyotyping, all that are going to come in this. Yeah, better Subir, I'll tell you. Yes, okay. Yes, receptor level problem. So that is it, okay. Yes. So now please pay attention. Please pay attention, all of you. Yes, again, very, very important MCQ. 25-year-old clinical case for all of you. 25-year-old cohabitating with the husband for 6 months, brought to the OPD by mother-in-law. Okay. Anybody, let mother-in-law, father-in-law, husband, anybody can bring up, but what will you do next? Anybody, what will you do next? Yeah, we're going to discuss more features. Yes, the karyotyping, all that I'm going to discuss in some time, so there is no confusion. Okay. B, option B. How many are saying B? How many would want to do semen analysis? How many would want to do HSG? What is HSG? Okay, yes. So very, very important. Please understand this. That is the same thing. Can anybody tell me? Can anybody tell me in one particular month when the husband wife are having or trying for pregnancy since 6 months, what is the chance? Is there any problem or there is no problem? So please understand this, very, very important. In one particular month when husband wife both, okay, husband wife, when both husband wife are normal, if the husband is also normal and the wife is also normal, okay, when husband wife both are normal, if they are trying, okay, both husband and wife, both of them are normal, in one particular month the chance of pregnancy is how much? Okay, in one particular month, my dear student, the chance of pregnancy is only 10 to 15%. I jokingly tell all my students and even all my patients, it only happens in Ekta Kapoor serial. Okay, it only happens in Ekta Kapoor serial and Hindi picture where hero heroine meet and heroine pregnant in the first shot itself. Okay, so this is nature. Yes, because if every month the female is conceiving, instead of 5 billion to 7 billion, will be 70 billion people on planet Earth. So कहने का मतलब क्या है? Please pay attention. कहने का मतलब क्या है कि yes sir, if they have not conceived in 6 months, nothing needs to be done, because definition of infertility we just now discussed is 1 year. Why not start investigating early? Because if you start investigating early, the stress goes up, and with stress the further success goes down. Yes, so please remember student that till 1 year, because unnecessary investigation is not going to help the patient. So you just have to tell the patient, relax, don't get too much stress, because if you start investigating early, there is less chance of success. So you tell them, abhi khali 6 mahina hua hai, go back home, enjoy. If after another 6 months also your wife is not becoming pregnant, you come back to me, and then I will start investigating. Is it clear to all of you? So here there is absolutely no need to do all these investigations. We will just give reassurance to the patient and send them back home, explain to them about the fertile period, tell them to relax, enjoy, yoga, meditation, yoga se hoga. Okay, yoga se hoga. Okay, is it clear to all of you? So just tell them to have reassurance. But one very important thing, can you tell me what can I tell them? What one medicine I can start? Yes, keep on trying for the 6 more months. Yes. Can anybody tell me what one thing I can start for any patient planning pregnancy? Anybody? I agree with you. Reassurance is the answer. Very good. After 1 year, Dr. Sam Doc, after 1 year. Okay. Yes. Anybody? What is this? Yes, very good, Kushal Rathod. Which vitamin specifically? Dhanya, Mary, all of you. Excellent. Folic acid supplementation definitely we should start for the patient folic acid supplementation. Don't make a mistake. Excellent, all of you, because folic acid is why it is important to prevent neural tube defect. So anybody planning pregnancy, it could be your cousin's auntie, if they call you and they tell me that doctor, I'm planning pregnancy, please start folic acid. Then now anybody tell me after 1 year what is the step? Yes sir, after 1 year you would like to start investigating. If after 1 year, then you start systematically investigating the male partner also, and you start investigating the female also, and male may you will do the semen analysis. It is called as HSA, husband semen analysis, or the sperm count. Okay, yes, not necessary, but letrozole is back doctor Jetka, that's baad mein. Letrozole, that is if there is ovulation induction. And for female, you will start investigating the various causes. You would want to do ultrasonography to see how the uterus is. You would want to then do her also hormonal investigations, how the things are, and also even HSG. What is HSG? Anybody? HSG is a tubal patency. Okay, it is a test for tubal patency. Okay, so all this is extremely important. Yes, extremely, all of you can. Okay, so all this will happen after 1 year. Yes, moving on, so folic acid supplementation. Now tell me, all of you, yes, this is why I have selected certain questions. Primary amenorrhea, well-developed breast, and well-developed axillary and pubic hair. Most likely USG finding. Anybody? Jai Vyas. Excellent, but thank you, because of thank you, super. Okay, spread the love, spread the happiness, and now try for PG also, beta. Jai Vyas. Okay, excellent. Yes. Yes, chalo. Anybody? What is this? So, 2 MCQ. Yes. No. Anybody? Now, two things. Streak ovaries. Streak ovaries we get in which condition? So, streak ovaries we get in Turner syndrome. Is this Turner syndrome? No, sir. Turner syndrome will not have well-developed breast. Well-developed breast, Turner's में कौन सा breast होता है? Shield shaped chest. Okay, Turner's syndrome, there is a shield shaped chest. Okay, Turner's syndrome, sir, ovary is not there, streak ovaries, so there is no estrogen. Please write down. Turner's syndrome, there is no estrogen. So if there is no estrogen, there will be no breast development is not there. Perfectly correct. So that is out. Okay, so this option is out. There is streak ovary, not possible. Again, streak ovary, not possible. And anybody, what is it? Well developed breast, but all of you are not reading. Yes, excellent. Well developed axillary and pubic hair. Please read. So if it's well developed axillary pubic hair, what is your diagnosis? RMKH. Sir, in RMKH, yes, fly high, Nidish Joya, and the answer is absent uterus normal ovary. Absent uterus normal ovary will present to us with primary amenorrhea, well-developed breast, well-developed axillary pubic hair. Okay, all those who are saying option D, can anybody tell me option D is now? All of you ध्यान से सुनेंगे. Okay, yes, RMKH. Now tell me this. Same MCQ, different MCQ. Is this a same MCQ? Is this a different MCQ? 16-year-old, primary amenorrhea, well-developed breast, but absence of axillary and pubic hair. So two back-to-back MCQs I have selected. Two back-to-back MCQs I have selected, which should cause confusion. Therefore, I'll clear the confusion. Yes, excellent. Now all of you, superb, my dears. Okay, so again, sir, it is well developed breast. It is well developed breast. So streak ovary option out. Streak ovary option out. And this is absence of axillary and pubic hair is the clincher. So all of you, diagnosis complete. Androgen insensitivity syndrome. complete androgen insensitivity syndrome. And all of you, those who have marked D is correct. Okay, sir, they have got absent uterus and they have got undescended testes. So very quickly, very quickly, I will quickly revise for all of you. Remember, students, that which are the only two conditions in whole of gynecology where there is primary amenorrhea along with absent uterus. Primary amenorrhea, absent uterus. Tell me the two conditions. Primary amenorrhea, absent uterus. Tell me the two conditions. Primary amenorrhea, absent uterus. Tell me. Yes. So MRKH or RMKH syndrome and androgen insensitivity syndrome. These are the two conditions. Excellent, all of you. And here, what is the gonad? So here the gonad present is ovary. Here the gonad present is testes, and testes in the no, but not imperforate hymen, Dr. Jitka, not imperforate hymen. Okay, imperforate hymen, the uterus is present. Okay, so these are the only two conditions. And one more important difference when you look at the axillary and pubic hair, what it is? Axillary and pubic hair, axillary and pubic hair will be well developed over here, and here they are going to be absent. Axillary and pubic hair is going to be absent, so please keep this in mind. Okay, in the whole of gynac, primary amenorrhea, absent uterus, only these two are the possibilities. Okay, and the difference is from axillary pubic hair. Here they are present and here they are absent. That is how you will keep in mind. Okay, yes. Chalo, now moving on to this. So I hope all of you, I'll very quickly tell you, this is your RMKH diagnosis because well developed axillary pubic hair, and therefore the answer is option number A, absent uterus, normal ovary. That is the answer to the first MCQ, the first one which we discussed, and not this. Okay, undescended testes hota hai dusre wale mein. Here the answer becomes this, absent uterus, undescended. This one beta, Nikhil Singh, this is TFS, testicular. Okay, हाँ, yes, okay, yes. Nikhil Singh, समझ में आ गया? What, which is same beta, TFS is the same as this only. Complete androgen insensitivity syndrome, another name is testicular feminization syndrome. Both mean the same thing. Okay, yes. So here it is absent uterus, undescended is why? Because of this absence of axillary pubic hair. Okay, Nikhil, समझ में आ गया बेटा? Nikhil Singh, TFS another name is CAIS. Okay, CAIS and TFS, the another name is the same thing. Okay, one another. Okay, moving on. So now, moving on to the next question, all of you. Yes, again, what is, chalo, so now we have discussed all this. So I've selected questions in such a way that your entire topic. So anybody, RMKH, what is it and what all structures in female does the Mullerian duct give rise to? Yes. So remember, students, beta medico, no. In complete androgen insensitivity, complete androgen is absent. That's absent, what you remember. Okay, sparse very rarely, but overall in complete androgen insensitivity syndrome, it is going to be absent only. Very rarely. Sparse, forget it, they will not confuse you, but they have written absence of active. So absence, sparse mean the same thing. Absence is you go for CAIS only. Okay, yes, perfectly correct. Now all of you look on the board. Females may go from above down, fallopian tube, uterus, cervix, and the upper part of the vagina. What all I have drawn in blue color, this is, yes beta, okay, what all I have drawn in blue color, this is my Mullerian derivative, and they are going to be absent in patients of Mullerian agenesis. Okay, that means fallopian tube, absent, uterus absent, cervix absent. Okay, okay, okay. But ovary, write down, ovary is not a Mullerian derivative. Okay, ovary is not a Mullerian derivative. Ovary is not a Mullerian derivative, and therefore ovary is perfectly normal. By this normal, it is normal in structure as well as function. Okay, structure also normal, function also normal. So this will produce estrogen also, this will produce eggs also. Okay, so I hope it is absolutely clear from all of you. Okay, ovaries are going to be perfectly normal in a patient of MRKH, or another name is Mullerian agenesis. Okay, so the answer is not uterus. Uterus is going to be absent. The question is, in a patient of IVF, which of the following is normal? Ovary. Remember, many students, when fourth option is all of the above, they mark all of the above as the answer. That's not the case over here. Okay, all of the above is not the answer. So ovary is the answer. Fallopian tube and uterus are going to be absent. Ovary is perfectly normal. Ovary is perfectly normal. Sanjay Nayak, what is hypergonadotropic hypogonadism? Yes, yes, yes. MRKH can have a biological child with surrogacy and IVF. Very good. Yes. So anybody tell me what is hyper? This your turners. What will master servant? Okay. So whenever all of you, whenever the ovaries are not functioning, if the ovaries are not functioning, what will happen from the brain? The pituitary brain. FSH secretion will become more or high. Okay. Anybody? No, but a Kalman syndrome, Ahmed Khan. Kalman is hypogonadotropic hypogonadism. Okay, all of you. Okay, I'll tell you, Kalman का भी MCQ आने वाला है. Don't worry, picture अभी बाकी है मेरे दोस्त, सब सिखाएंगे आपको. Okay, yes. So whenever ovarian function is completely over or getting over, anybody, what happens to the FSH? FSH, very good. Sam Newton, FSH is going to increase. That is your this. That is hypergonadotropin. Yes, FSH more. So this condition is called as hypergonadotropic hypogonadism. Okay, hypergonadotropic hypogonadism, anywhere the ovarian failure. So premature ovarian failure, diminished ovarian reserve, all this. Okay, all conditions of example premature ovarian failure is an example of this. Or even your Turner's syndrome, basically ovarian failure, diminished ovarian reserve, all these cases it is hypergonadotropic hypogonadism. Kalman's we are going to come in sometime. Okay, is it clear to all of you? Yes. Moving on, match the column. New style of asking question. Yes, man. Okay, correct. New style of asking question, match the column. One question, 4 questions. Clap if you feel happy with one MCQ. Yes, gonadal region is also example. Perfectly correct. Yes, yes. Now, anybody, Turner's syndrome, what is the karyotype? Turner's syndrome, what is the karyotype? Okay. Okay, Turner's syndrome 45XO is the karyotype, all of us know. So 1 is going with A. See, in match the column always, so you know 1 is A. So option C, option D ruled out. Option C, option C. RMKH, we just now discussed RMKH is XX. RMKH is 46XX. So 2 is going with C, and CAIS, androgen insensitivity, all of you, yes sir, Y chromosome. So 46XY. Okay, 46XY. So 3B, and Klinefelter syndrome 47XXY. Perfectly correct. So I love match the columns, and match the column kind of questions have started coming. in various exams, and they are being asked in the definitely in the exam. Yes, all of you correct. So option B is the answer. 1A, 2C, 3B, 4D is the answer. It is not 2B. Okay, 2 is not B, so this is wrong. 3 is not C. Okay, yes, is this understood to all of you? So please don't make a mistake. This is very popular MCQ, and I hope I have covered 4 things for you in your exam. All could be asked to you in the exam. Okay, Turner syndrome, will just remember, Turner syndrome is your streak ovaries, shield shaped chest. Yes, moving on to the next question. Moving on to the next question. As per the latest criteria, what is BPP? Anybody? What is BPP? Now obstetric MCQ. Anybody? It's going to be mixed, obs and gynae both. Okay. Again, previous year. So all, as I said, all these are extremely important past year papers, or they are also previous year, or they are virgin MCQs. What is modified BPP and what is BPP, and what criteria it is called as? Whose criteria? Anybody? BPP is whose criteria? Yes, Manning's score. Manning's score. Biophysical profile. Yes, so please don't get confused, student. This latest criteria is just given to confuse you. Latest is just given to confuse you. There is in BPP, chalo, tell me, first of all, tell me, in BPP how many criterias are there? In BPP how many criterias are there? Anybody? Tell me the 5 criterias of BPP. So with every MCQ I discuss something extra also. Yes, Manning score, very good. And AFI and NST, very good. What is AFI? Amniotic fluid index. So NST and AFI is the answer to this MCQ. Perfectly correct. It is done to save time. Okay, please don't make a mistake in this. Very good, Garima, and very good, Ilaya and Raju, and all of you correct. So totally for Manning score, there are 5 criterias. Which are the 5 criterias? NST is a part of it. NST is a part of it. Very good. Fetal breathing movement. I'm writing BM. Fetal gross body movement, fetal movements. And number 4 is fetal tone. And number 5, Liker pocket or amniotic fluid volume. And all of us should know that each component is given a score of 2 or 0. Okay, each component is given a score of 2 or 0. That means if the NST normal give 2, non-reactive, breathing present, absent, movement present, absent, tone present, absent, fluid value normal, 0. Okay, and therefore 10 by 10, 10 by 10 baby is takatak. Okay, 10 by 10 the baby is takatak, and 10 by 10, 10 by 10 the baby is absolutely good and healthy. And as the score is decreasing, then there is problem with the baby, like 8 by 10 slight problem, 6 by 10 more problem, 5 by 10 still, 4 by 10, and then 2 by 10, all as the score. And remember, it's always a even number. The score cannot be odd. Okay, 2, 4, 6, 8, 10 is now the scoring system. Now the last and the important, yes, to save time I do modified BPP. Therefore AFI and NST and AFI is the modified BPP. Okay, modified BPP. Okay, this is the answer. Okay, now yes, it tells us about the test for fetal well-being. That's the answer. Okay, now anybody can you tell me, in this fetal movement, who will count the fetal movement? In BPP, who will count the fetal movement? Chalo, one more MCQ. Virgin MCQ. Fetal movement in biophysical profile, who will count? Mother, father, neighbor, intern. Mother, father, intern, radiologist. Garima, NST is non-stress test. NST is non-stress test. NST is non-stress test. Okay, Garima, that's a part of your non-stress test. It's a machine where you have to have a reactive NST. And my dear students, sorry to tell, all of you are wrong. I'm so happy I teach this name. Okay, okay, yes, okay. All of you, those who said that in BPP, fetal movement, the mother will count. Wrong, wrong, wrong. Yes, Garima. Okay, mother will count the fetal movement. That's called as fetal kick count. I'm so happy I teach this every year. And this was the MCQ 1 year back also in INICET and likely to be repeated in the upcoming exams also. Please understand, mother counting the fetal movement is called as fetal kick count, and mother will not count the movement in BPP. Fetal kick count is a separate where mother will count. In fetal movements, you have to count with the help of ultrasonography and therefore a radiologist. Absolutely correct. Okay, so Mahima, Ashwin, and all of you correct. Ramaya, yes, radio. Okay, so this is very important. Don't make a mistake that for BPP scoring for BPP scoring, you require compulsory ultrasonography to be done. Is this understood to all of you? All these things are done on ultrasonography. Okay, clap if you have learned something new. Clap if you have learned something new. OG Guru in the chat box if you are loving the session, and clap and appreciation if you're liking it. Okay, is it understood? Remember, students, that fetal breathing movement, stone, amniotic fluid is done with the help of ultrasonography. For BPP, USG machine is compulsory requirement. Okay, is this understood to all of you? Yes. So please remember, it is not the mother, it is the radiologist who is there. Yes. Okay. Okay. So let us now go on to the next MCQ. Echo coming. Okay, I'll try to see there's some echoic noise. Okay, I'll try to see, Dr. Anil. Let me just see. I'll try to see what the noise is, but there's no echo. I've kept the device under this. Let me just see. Okay. Yes. Yes. Yes, all of you. Yes, moving on. Now again a clinical case scenario. Clinical case, longest question. Please pay attention. Patient is anxious to conceive. Profuse white discharge around the 12th day of the cycle, which is the most probable diagnosis. And no, the most important part, no history of itching present. No itching. No itching. Yeah, thank you, Rajiv. Thank you for your love and appreciation. Yes, yes, just yeah. So definitely do subscribe to the app, and yes, all of you. Yeah, I'm trying to see, but I'm also not able to know from where the voice is coming. Let me just see. Hopefully, I will try to get the noise better. Let me just see. Yes. Okay. Yeah. So point number one. Point number one. Yes, this is a physiological discharge. This is a physiological discharge. The reason is that there is no itching. Yes. In all the other things, in all the candidiasis, there would be lot of itching. Trichomonas also itching. So all of you correct. This is physiological. Why? Because around 12th day, what is going to happen around the middle of the cycle? Yes, bacterial vagina is also foul smelling discharge. All that we're going to discuss. So this is physiological discharge. Why does it happen? Anybody? Why does it happen? Anybody? Yes, because around the mid-menstrual 12th day, so when there is ovulation, okay, if it's a 28-day cycle, around the 14th day, there is going to be ovulation. There's going to be ovulation around the 14th day, and therefore, Therefore, there is going to be ovulation on the 14th day, and therefore, around that time, the cervical mucus will become very thin, watery vaginal discharge. Okay, there's going to be watery vaginal discharge starting from the 12th, 13th day. Okay, that tells you yes, the fertile period, watery, clear. Just a second, all of you, I'll just try to get the okay, watery, clear discharge. Watery clear discharge around the time of ovulation. Okay, around the time of ovulation will be happening. This is a sign that the patient is going to ovulate. Yes, perfectly correct, all of you. Now the image based question. No, beta, Mahendra, not thin because of estrogen. Okay, thin because of estrogen. Okay, the thin discharge is because of estrogen after ovulation. Post ovulation, then it becomes thick. Okay, that is because progesterone is coming after. Okay, so progesterone will be after. So progesterone is going to make the mucus thick. Okay, yes, very, very important. Identify the device. Anybody wants the device? Uh, yeah, Prashant, they're not compulsory, but yes, most of the females will have it. Some may not notice it. Okay. No, ectopic can happen. No, no, no. First, what is this? Yes, very good. Arakadeep, Garima, Medico, beta, IUCD, which IUCD? Don't you say, okay. If you miss that, that's okay. Okay, Prashant, then there is also sonography to find out. So the device is very good. The device is called LNG intrauterine device. We'll also discuss in the next question. And Myrina is the brand name. Myrina is the brand name, but there is LNG intrauterine device. Excellent, all of you. So what will it do? What does Myrina do? Apart from birth control, there are a lot of non-contraceptive benefits. Can anybody tell me what happens to the menses? What happens to the menses? What happens to the menses when I put Myrina inside the uterus? So when we put Myrina inside the uterus of somebody's uterus, what will happen? Yes, Myrina will make the Myrina, yes, it's a hormonal device. Myrina is continuously releasing progesterone. Myrina is continuously releasing progesterone, and that progesterone counteracts estrogen. So estrogen will not allow the lining to grow. Under the influence of estrogen, the lining is growing, isn't it? So because of continuous progesterone exposure, no beta super bleeding will not increase. All of you know, regular menses you require occipils. Bleeding will become less. Yes, because progesterone will not allow lining to grow. So the lining will remain very, very thin. And if the lining remains very, very thin, what happens to the menses? The menses will become scanty. Menses will become scanty, and menses can even stop. This is perfectly safe. This is called as progesterone induced amenorrhea. Okay, progesterone induced amenorrhea, please keep this point in mind. Yes, so very good, Arakdeep. It will become scanty and then stop. And Elizabeth, correct. So because the menses will become scanty, they are used in treatment of endometrial hyperplasia because it is progesterone, and it will also decrease the dysmenorrhea as well as menorrhagia. It is one of the most important treatments for menorrhagia. Excellent, all of you. Okay, so it is like, but sir, if the patient is not getting her periods, is it okay? Yes, sir. Why? Because all of you pay attention. What is the logic? That you will shave only when the beard is growing. Okay, only if the beard is growing, then you need to shave. If the beard is not growing only, Tiger Shroff, then what will you shave? Okay, so if the beard is not growing only, like Tiger Shroff, when he came many years back, he didn't have beard. Now we did some transplant and now we have started getting beard. So when there is lining is very thin, there is no lining to grow. So if there is no lining to grow, there is nothing to shed out. So there is no need to fear, yes, the progesterone induced amenorrhea. Because of the progesterone induced amenorrhea, the menses will be scanty and stop, and therefore there is the menses becoming scanty, and this is very helpful for patients who have got menorrhagia. Therefore it's one of the main treatments for menorrhagia. And one of the most important point also, all of you, what happens to the cervical mucus? Cervical mucus will become thick. Cervical mucus will become thick, isn't it? Cervical mucus will become thick. So if cervical mucus will become thick, what happens to the risk of PID? Please keep all these points in mind, my dear student. If the cervical mucus will become thick, the good part is that, sir, the cervical mucus is going to become very thick. So any infection in the vagina, suppose if there is any infection in the vagina, cannot spread up. The infection cannot spread up, and therefore tubes will remain healthy. If the cervical mucus becomes thick, what will happen to PID episodes? Pelvic inflammatory disease. PID episodes will decrease. And if PID episodes will decrease, there is also decrease in ectopic pregnancy. Very good, all of you. And therefore, even this is correct. So the answer, clap if you have understood this. Don't make a mistake. It is all are true except. Okay, all are true except. So this is also correct. This is also correct. This is also correct. This is the answer. Okay, if this except is not there, that means benefits are all, then all of the above. Okay, basically all of the above are benefits. So this is how, this is a very difficult concept, but Mirena protects against ectopic pregnancy. Please write down. If there is acute PID, Arakdeep, correct. If there's acute PID, you can't insert copper T. Okay, or any IUD, correct. But if there's already PID, then you can't. I'm saying overall it's going to protect. Okay, it's going to prevent, it's going to decrease PID episodes from happening. Okay, acute PID, yes, you can't insert IUCD. I agree with all of you. So just to discuss in 1 hour how many. Okay, so just a second, all of you. So 1, 2, 6. Yeah. Okay, excellent. So now let us go on. We're entering the second hour. Yes, all of you. Very good. Chalo. Very important MCQ surely coming in the future exams. Okay. Mrs. XYZ married for 1 month. Beta Avni, when there is acute pelvic inflammatory disease, when there is already a existing PID, we cannot insert because there's a lot of inflammation, infection, patient will be having fever, cervical mucus discharge. So there's tenderness. Okay. So let the PID episode settle down. Yes, perfectly correct. The patient wants to delay pregnancy at least for a year. Okay, and they are married for 1 year. So this is a contraception of choice for a newly healthy married couple. Okay, both partners are healthy. Okay, both partners are healthy. What is the best advice? What is the best advice? Yes. Now let us start one by one. Vasectomy out of question. Obviously, if you do vasectomy in a patient who is just married for 1 month, you have to go to jail. Okay. So vasectomy is a permanent method. We don't do that. Spermicidal agent, very high failure rate, and again we don't prefer that. Similarly, condoms slightly decrease the sexual pleasure, and they have also got very high failure rate. And when they want to delay pregnancy at least for a year, then OC pills is the best. Very good, all of you. And the other clue given to you is, Beta, we can just try to see. I'm also not able to see, but actually I was, it's absolutely quiet from my clinic. I'm in my clinic and I'll try to speak to them. Just give me some time. Yes, I also know that noise is disturbing me. Then between the noises going, I'll just try to see what can be done. Yes, okay. Yes, but I think it should settle down. Okay. So both partners are healthy. This is the clue given to you. So OC pills. Okay. OC pills is the answer. OC pills is the answer because OC pills is good for, you can use for 2-3 years. IUCD, she is just married since 1 month, so she is a nulliparous patient. So in a nulliparous patient and just want to delaying for a year, IUCD we want to avoid. It's not that you can't use it. IUCD better to avoid in a nulliparous. Yeah, I'm coming to that. Yeah, beta, it is IUD, IUCD both mean the same thing. Okay, Mahendra, why not IUCD? It is intrauterine. Whether you call it IUCD or IUD, both mean the same thing. Yes. So there is a chance of complication which can happen. So I'll explain to you when we give IUCD also. Okay, medic. So remember IUCD. Why not? Because in a nulliparous patient, IUCD, whether you call it first of all IUCD, intrauterine contraceptive device, or you call it intrauterine device, both mean the same thing. Okay, so that's the same thing. Yes, Akib Bhagwan has given the answer that IUCD better to avoid. Okay, better to avoid in nulliparous. It's not that you can't give it in nulliparous patient. Nulliparous patient, you better to avoid IUDs. IUD is best after one baby, and IUCD is when you want gap for 3 years, 4 years, 5 years. Okay, therefore, can anybody tell me which scenario IUCD becomes the best? Which scenario? Just give me, okay. Which scenario IUCD becomes the best? Yes, IUCD becomes the best. IUCD is called as spacer devices after one baby delivery. Yes, very good. Those who said Eli and Raju. Yes, when one baby is delivered and there is a spacer devices, then you want to space in between baby for 3 years, 5 years. That is the time. So after one baby in the postpartum period, okay, in the postpartum period, and after one baby, IUCD the best. Okay, just give me a minute. Let's just, it's exactly 5 o'clock, 1 hour, a small tiny 2 minutes, 1 2 minute break, 1 2 minute break. All of you, we just give me a minute, just quickly get something for me to drink. Okay, just give me a 2 minute break and we are coming back. Okay, don't go anywhere far, just starting again in a 1 minute time. Okay. Yes. Okay, 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 all of you. Okay. Okay. So am I visible to all? Am I audible to all of you? Yes. Okay. So IUCD, IUCD, IUCD is best considered for spacer devices when we have to space in between the two babies, and in the postpartum period and after delivery. Remember students, IUCD is the best. Okay, so if they tell you that a patient has delivered one baby, and then if they want a gap of 3 to 5 years, then the best answer would be IUCD. Is this understood? In a nulliparous healthy couple, in a nulliparous healthy couple married for 1 year, 1 month only, and wanting to delay only for 1 year, OC pills is the best suited. IUCD is better to avoid in a nulliparous patient. Okay. Yes. Okay. Moving on. Moving on. Yes. Now, anybody, what is this image? Identify the image. Even this exact, only this image had come in the exam, and they had said, what is this modality? Anybody? If the couple are staying far away, better in far away patient, what happens is that at that time you can tell the couple to go for either condoms definitely for the act of sex and I pill as a backup, and then in that case every day taking OC pill does not make sense. Correct. If they are staying long distance away, then either IUCD can be done or mainly barrier can be used, and barrier के साथ backup of emergency contraception can also be. Yes, so this is a where we can see some uterus and a dye and the spill. So this is HSG, hysterosalping. Yes, yes. Okay, the condoms is the okay. Hysterosalpingography, very good, Vikram Yadav. I was going to tell you the same thing. It is done. Can you see, all of you see this instrument? Can all of you see this instrument? What is over here? Can all of you see this instrument? Yes, this instrument which all of you, it's now my white pointer I'm showing you, that is, yes, this is difficult to say, not a very clean image, but this side is completely blocked, correct, and your side some spill is there, not a, okay, not a, this. Okay, so yes, so point is, yes, we are going to tell you. So this is point number one. This instrument what you are seeing is called as the Colvin's cannula. Colvin's cannula, also called as, yes, Elizabeth Joshi, Leach Wilkinson. Okay, so done with the help of Leach Wilkinson cannula or a Colvin's cannula. Please keep this in mind, and it is done on which day of the cycle? Anybody? The question is HSG done best when? Day 2 to day 3, day 7 to day 9, day 13 to day 15, day 21 to day 25. Anybody with the answer? Mahendra, day 2, no. Ramya, no. Yes. Akib, correct. Suchitra, no. Okay. So yes, Mahendra, correct. Okay. So all of you remember that HSG, day 2, day 3, the patient is still bleeding. Isn't it? The bleeding is still going on. It's a X-ray. In the X-ray, what are during menses? No medico. During menses, we don't want that, because when you push the dye, what will happen? The blood will go black flow. What can happen? Patient is bleeding. Patient is bleeding, blood is coming out. You don't want to push the dye, back pressure, risk of endometriosis, yes, backflow of the blood. So never do while the patient is bleeding. Okay, day 7 to day 9 is the best answer. Day 8, day 9, because bleeding is for 4 to 5 days. Yes, she will be in menses, and when you push the dye, risk of there's going to be a risk of endometriosis. And 13 to 15, you are correct, it is the time of ovulation. We want to avoid, this is a x-ray, even though the radiation is low, even though the radiation is still low, but it's x-ray. I don't want to expose the ovum to radiation. And day 21 to day 25, so never. Anybody, why never? Why never day 21 to day 25? Yes, correct. So day 2, day 3, bleeding, risk of endometriosis. Nobody tell me why day 21 to day 25 never. Yes, very good. Mahendra Elizabeth Joshi, that is a patient may be pregnant, and I don't want to accidentally, while pushing the dye and all that, damage the pregnancy. So never do anything. So the answer, remember student, very popular MCQ, day 7 to day 9, day 8, day 9 is the answer, which is when we do the HSG. And very quickly, I will also tell you how the normal HSG looks like. So this is the uterus. The dye will fall on, why you see the tube, thin, bouncy, wavy tube. And this U is called what? This is the spill of the dye. This is called as the spill of the dye. That means it is, the tube is patent. And can anybody tell me what this is considered the initial investigation? Okay, this is considered the initial investigation for tubal patency. Which is the best investigation for tubal patency? So water soluble dye is also there, oil soluble, any water soluble dye can be used, oil soluble dye can also be, lipidiol is also used, lipidiol is also, and water soluble dye can also be used. Yes, very good, Akib, and all of you. No, but Elizabeth, oh, that is for this. Okay, so best investigation for tubal patency is laparoscopy. Laparoscopy and chromopertubation. I'll show you discuss today only. Okay, there what we, okay, so laparoscopy, chromopertubation, what it is I will tell you. All of you, superb. That is the best investigation for tubal patency. That's the best investigation for tubal patency is your laparoscopy tubal ligation. Okay, laparoscopic chromopertubation, not tubal. Laparoscopic chromopertubation is the best investigation for tubal patency. Now just coming to this, because this is slightly what everybody wants. So here I am seeing only the uterus. We are seeing the uterus, and clearly yes, there is no dye coming over here on this side. So if this is the right side, definitely the right tube is blocked. It's the right sided cornual block for sure. It's not a very best quality, but we have taken the same image which has come in the exam. Okay, in the actual classes we'll also show you the lots of actual HSGs. Also I'll be showing you in the actual classes, where we'll show you Asherman syndrome, filling defects, all that I'll show you. And here some amount of dye has entered over here, and some spill I can see, though not very clearly. Yes, so, and this is somehow, most of the, it's looking like a dye has extravasated also. So not a very nice picture, but yes, definitely one side the block is there. Okay, and something has been over here, so that's okay. Mainly that only asked you what it is. It is a hysterosalpingography, x-ray with a contrast material. Okay, yes, right side corner block for sure. Okay, and this is the normal HSG, normal uterus, normal spill, which is considered this. Okay, yes. Bilateral cornual block will be like how, students? Bilateral cornual block will be only the uterus will be seen. So if you get this, okay, if you see this picture, then we call it as bilateral cornual block. Okay. Okay, this is your bilateral cornual block. Both the ends are blocked at the cornual end, or it could also be a spasm. What's the difference between a spasm and a block? Spasm is a temporary smooth muscle contraction. Okay, so this is how your bilateral cornual block. Yes, only the uterus will be seen. Absolutely correct. Yes. Now, very important. Again, a clinical case. This has been asked in the previous year question, and what it is. Okay. Patient has come to us with the USG finding of some uterine anomaly. Some uterine anomaly is there. Which is the best way to confirm the diagnosis? Anybody? Yes, all of you correct, all of you correct. Not only laparoscopy, why not only laparoscopy? Hysterolaparoscopy. Okay, when you put in double telescope, I will come to know all types. Okay, no beta. Sonography is again this one, it is a USG. So transvaginal sonography again not, and HSG is not confirmatory. Seeing is believing. Now, can you tell me how both hysterolaparoscopy will tell you? Yes, sir. That please pay attention, that when you put in a telescope from above, which is this telescope? This is the laparoscopy view. When you put a telescope through the abdominal cavity into the pelvis, that is your laparoscopy. So here what all laparoscopy will tell you? Sir, suppose it is only unicornuate uterus, one horn. Okay, one horn. No beta, Dhivakaran as gold standard is not MRI beta. Okay, gold standard or 100% confirmatory is hysterolaparoscopy only, because MRI will again give only it will only give you very likely, it cannot be confirmed because MRI is also a shadow. Okay, remember all the USG, MRI, 3D USG, all will tell you with likelihood very sure, but 100% seeing is believing. Why B is the answer? Because with your own eyes, write down all of you, seeing is believing. I am seeing it. Confirm अपने आंखों से हमने देख लिया, inside and outside. Very good, Anu Moyal. Okay, so laparoscopy is the outer view. So here if it is a unicornuate uterus, okay, only one side horn, that will be seen. If it's a two separate horns, this is what? Bicornuate. Okay, so bicornuate also two separate horns are there. You will come to know two separate horns wide apart. All that laparoscopy will tell you. Okay, laparoscopy will tell you. That is correct. And can anybody tell me, when I put a telescope through the cervix into the uterus, this is your hysteroscopy. Okay, so in hysteroscopy we will, yes, very good. So if there is yes, if there is a septum, inside septate uterus, one of the most common, okay, one of the commonest uterine anomaly is septate uterus, whichever hysteroscopy will tell you. Okay, so clap if you feel happy. What I tell all my student is, That laparoscopy is the terrace view. We are seeing from above, terrace view. From the outside you are seeing everything, so it's a terrace view. And hysteroscopy is inside the classroom view. Okay, inside the classroom we are seeing what is inside the cavity of the uterus. Whenever I want to see the cavity, we have to make use of hysteroscopy. Hysteroscopy is to have a look at all the cavity. Okay, so therefore remember students, for any Mullerian anomaly, hysteroscopy and laparoscopy is the confirmed. Not only laparoscopy. Okay, C is not the best answer. B is much better than C. Okay, B option is much better compared to option C, and therefore option B is the answer. Because anyway sir, I have given anesthesia to the patient, I am anyway taking the patient to the operation theater, and therefore do put one more telescope, no harm. Hysteroscopy, laparoscopy is to confirm any Mullerian uterine anomaly, or any Mullerian anomaly can be told you. Unicornuate uterus, bicornuate uterus, adelphius, all that. This one bicornuate you can see on laparoscopy, and septate uterus or septum we can see with hysteroscopy. Very important. Yes, I'm so happy we teach this every year, and 100% coming again in this year's exam. Okay, anybody, what is the answer? Yes, very good, all of you. Midline septum inside the uterus. That means we are discussing about septate uterus, and laparoscopy no role. Laparoscopy no role, because where is the septum? So septum is within the cavity. Septum is within the cavity, projecting into the cavity, and therefore laparoscopy has got no role, my dear students. Laparoscopy will be normal, because when you laparoscopy will do the outer surface, isn't it? Outer surface will appear normal. I have to put in a telescope. Perfectly correct, all of you. And with the help of a scissors, you keep on cutting, cut, and you cut the whole thing. That is how the see, you're cutting like this, and you make the cavity normal. Okay, so perfectly correct, all of you. Hysteroscopy, septoplasty word use कर सकते हैं, या hysteroscopy septal resection also can be done. Hysteroscopy septal resection can also be done. Okay, so please keep in mind, laparoscopy has got no role over here, because septum is within the cavity of the uterus. So all these are extremely important questions. You will remember me on the day of the exam is my guarantee. And hysteroscopy septal resection is the answer, or hysteroscopic septoplasty. Okay, moving on. Yes, again very important. Hysteroscopy is for all except. Hysteroscopy is for all except. Next MCQ. बेटा इट इज ट्रांस सर्वाइकल ओनली बेटा. वो जो आप बोल रहे हो टीसी ट्रांस सर्वाइकल सेप्टम रिसेक्शन नहीं होता है, ट्रांस सर्वाइकल एंडोमेट्रियल रिसेक्शन. ओके मेडिको, you are doing trans cervical only. Okay, through the cervix only we are going, but trans cervical you will not be able to reach inside, so it is through cervix only. Okay, we are going, hysteroscope is put through the cervix, trans cervical, but it's not called, it is trans cervical but through hysteroscopy guidance, with the help of hysteroscopy scissors. There's a hysteroscope and there's a scissors. Okay, hysteroscopy scissors होता है या cautery होता है, and with current you either cut, or with the scissors you cut the septum. Okay, is it clear? So it is trans cervical only, you are correct, it is through the cervix only, but it is done through hysteroscopy guidance, hysteroscopic guided. Yes, Perfectly correct, perfectly correct, that hysteroscopy is to see the cavity of the uterus. Anybody, anybody, what is adenomyosis? Can anybody tell me why is adenomyosis the answer? Okay, so in a patient, what is, first of all, tell me what is Asherman syndrome? Anybody, what is Asherman syndrome? Anybody, what is Asherman syndrome? Yes, all of you correct. D is the answer. And what do you do for D? Yes, very good, Elizabeth. So D is adenomyosis. Adenomyosis is presence of endometrial glands within the myometrium. Okay, there are like this multiple cystic spaces. Presence of endometrial glands. Endometrial glands within myometrium. Perfectly correct. Perfectly correct. No, but I'll tell you, okay? So presence of endometrial glands within the myometrium, this is adenomyosis. And for this, we need to do either ultrasonography. Yeah, laparoscopy is more beta. Akib Bhagwan, laparoscopy is more when you can see like a fibroid. Okay, when there's actually a fibroid or something, then you might see on laparoscope. Or if it's a adenomyoma, if it's a adenomyoma with a localized adenomyosis, when it's scattered adenomyosis, again laparoscopy, because it's within the myometrium. So ultrasonography or MRI. Ultrasonography or MRI will tell us about adenomyosis. USG generally done. USG is good enough. Of course, confirmation then MRI. Okay. Yes. So USG or this. Coming to the MCQ. So coming to the MCQ, Asherman syndrome, all of you correct. Intrauterine adhesions. Why do we get? We are going to discuss a separate MCQ. There are intrauterine adhesions. That is your Asherman syndrome. So of course hysteroscopy will help me for that. Anybody, which causes of menorrhagia I can pick up? Which are the causes of menorrhagia which can be picked up on hysteroscopy? Yes, sir, polyp. If it is a polyp or if it is a submucosal fibroid. Very good, Mahendra. Okay, and all of you. So if it's an endometrial polyp or a fibroid, then I can pick up, when I can pick it up on a patient of hysteroscopy by putting in doing a hysteroscopy. And of course all this what is there inside would also lead to infertility because the cavity is abnormal. So even for infertile patient we may do hysteroscopy. So as you can see, as all of you can see, for ABC patients hysteroscopy has a role for cavity of the uterus. Adenomyosis is the answer because adenomyosis will require a simple ultrasonography. Ultrasonography, okay, multiple cystic hypoechoic spaces within the myometrium you will see. Okay, this is what you see. Okay, and also there's this like salt and pepper, and there is also you get the basically endometrial myometrial junction zone. Okay, the endometrial myometrial junction is fuzzy. Okay, and that Venetian blind, yes, because it is okay. So adenomyosis, USG or MRI. Okay, Venetian blind appearance also, yes. So hysteroscopy is for all except the very important MCQ. Please don't make a mistake. Surely will come in the exam for all of you. Okay, yes. Again, a previous year MCQ. Can anybody tell me? Can anybody tell me what is this instrument and what number will I use? Color coding you don't have to remember. Okay, but this is again very likely to be asked in the exam. Yes, very good. What is this instrument? What is this instrument? Yes. So this is for MTP. MTP. This is used with which machine? Yes. So this is used with your MVA, manual vacuum aspiration. And perfectly correct, Samir. Number is the gestational age. Yes, these are the Carmen. Very good. So these are the plastic cannula. These are the plastic cannula, also called as the Carmen's cannula. And 8 weeks hai. So you dilate it, and this also acts as a dilator. Okay, the advantage is that the same instrument will act also as a dilator. So you don't have to use a separate Hagas dilator. This will act as a dilator, plus then you attach it to the MVA syringe. So it is used along with MVA syringe. Okay, it is used along with MVA syringe. Okay, and whatever may be the weeks, if it is 8 weeks pregnant patient, then 8 weeks, 10 weeks, 10. So question is telling you 8 weeks. So this is the 8. Okay, yes. Good evening, Parad. Yes, very good. Okay. So remember 8 weeks for a number of gestation. And can anybody tell me this MVA syringe can be used till how many weeks of gestation? MVA syringe, if I tell you MVA as a method for MTP, MVA syringe can be used up to 8 weeks, 12 weeks, 16 weeks, 24 weeks. So with one MCQ, I'm showing you every 2-3 extra MCQs. MVA can be used for MTP till how many weeks of gestation? Yes, excellent all of you. Sir, MVA syringe can be used up to 12 weeks. Okay, up to 12 weeks we can use it. Yeah, 7 to 8, 9 to 12 weeks to compulsory, because up to 9 weeks the medical. We are going to come to that also. 16 weeks never ever use it, and 24 also never. Never in the second trimester, only in T1. Okay, only in the first trimester. Okay, why? Because the second trimester baby is this big. I can never suck out the whole baby. Second trimester, I have to make the uterus contract and go for mini labor or delivery. Okay, we are going to discuss MTP laws and all that also. Yes, overall MTP is till 24 weeks. The question is MVA allowed till how many weeks? Okay, so MVA is allowed till not 8, 12 weeks is the answer. Yes, very simple MCQ, virgin MCQ. Patient has history of dribbling of urine on coughing and straining and also normal urination. Yeah, but so CHS, that's a very big, so you need to attend a whole lecture series. We'll try to give you. Okay. So CHS, do subscribe to the app at each and every method of delivery. So when there's malpresentation or primary with pitch, already we might have to do C-section. Fetal distress, we might have to do C-section. Placenta previa, we do C-section. But other cases, then you try for normal also. Yes. So this is a simple condition, SUI, stress urinary incontinence. Stress urinary incontinence, where on coughing, laughing, sneezing, there is leakage of urine. Okay, dribbling of urine on coughing. Coughing is basically going to increase our intra-abdominal pressure. So any condition where the intra-abdominal pressure is going to be increasing, that is stress urinary incontinence. Can anybody tell me if there is a fistula, VVF में क्या होता है? What happens in a patient of VVF? In a patient of vesico-vaginal fistula, what happens? Anybody? In a patient of vesico-vaginal fistula, there is continuous dribbling of urine. Isn't it, student? There is continuous dribbling of urine, because this is the... Barad will discuss that, but a question aayega. Okay, Barad? Yes, I'll explain to you. Okay, so just hold. Okay, so the urine comes out from here, and the urine comes out through the fistula, and urine is out. Okay, so in a patient of VVF, there is a continuous dribbling. Yes, continuous dribbling of urine is there, and along with that, there is ammoniacal smell coming from the patient's clothes. Okay, ammoniacal smell. Patient walks to you in the OPD and you will come to know. You get that typical smell which you get in the washroom, in the bathroom, in that stinky toilet, and you tell the patient, "Aapko VVF hai." Patient will become your fan lifelong. Okay, I went to the OPD, I did not even open my mouth. अंदर OPD में डॉक्टर ने अंदर भगवान बैठे हैं. Okay, patient will tell other, okay, I did not even open my mouth and doctor told me what my diagnosis is. Okay, so in VVF, there is a continuous dribbling of urine, and along with it, ammoniacal smell coming from the patient's clothes. Okay, yes. Yes. Now again a clinical case scenario, and all of you tell me the diagnosis. All of you tell me the diagnosis here. Chalo. Longest question, read carefully, and I want the diagnosis for from all of you. Yes. Yeah. We are coming to better GP. Yeah. Hitesh Yadav and Brad also I'll tell you. Okay, yeah. So NTs can also I'll discuss, and your GP formal also I'll try. Okay, let me first discuss whatever questions I have got, and then. Yes, so this is a patient who at 32 weeks of gestation, at 32 weeks has come with pain in abdomen. There are uterine contractions, so it and cervix has started to dilate. So she is coming in like threatened preterm. Yes, okay, preterm contractions have started. But anybody, can you tell me, BP is how much given? BP 110/70. BP 110/70. Then can anybody tell me why are we giving nifedipine? So nifedipine why are we giving? BP तो normal है. Anybody, why are we giving nifedipine? Chalo, tell me in the chat box. Yes. No, this is not abruption, beta. Abruption में you get bleeding. Okay, so Sudev Suresh, abruption में the uterus is tonically contracted and there is bleeding. Here there is no leaking of lycurcine. Abruption is going to have bleeding. Yes, excellent, all of you. Nifedipine has got nothing to do with the blood pressure over here. Blood pressure is normal. Yes, we know. Nifedipine here is a tocolytic agent. Excellent, all of you. We are giving nifedipine as a tocolytic agent. So this will definitely be given. Steroids will also be given. Anybody, why do we give steroids for? For lung maturity, because patient is only 32 weeks. God forbid if she will deliver. So for RDS prevention, we are going to give patient steroids. We are going to give patient steroids to stop the contraction, and the answer is simple: immediate delivery, isn't it? There is no need of immediate delivery. Okay, The answer is option number C. There is no need of immediate delivery. Mother is stable, baby is stable. Look at the baby heart rate, 130. There is no leaking also. Why would I do immediate delivery when it is only 32 weeks? Okay, immediate delivery is done when suppose there is fetal distress or mother is having some abrupt all that. Okay, so none of the above is not the answer. Steroids. So anybody, it's simple that whenever we have a patient of preterm labor, three thing: steroid, tocolytic, bed rest. Okay, steroids you will give S, I'm writing, tocolytic, and of course you can't tell the patient to be moving around and jumping and dancing, so bed rest. So this is my treatment for preterm: steroids to this, tocolytic agents. Okay, tocolytic agents, steroids, tocolytics, bed rest, that is the treatment. Yes, perfectly correct. So immediate delivery is the answer over here. Okay, yes. Now very important, all of us know or should know this, that now in MTP Act, now up of the new guidelines of 2021, MTP is allowed till how many weeks of gestation? Yes, so perfectly correct. That sir, now the MTP has been changed. Now, can anybody tell me this 20? It was till 20. 20 was the old answer, and we have raised the limit from 20 till 24. Can you tell me for which all condition we are increasing? This 20 was there, we increase the limit to 24 weeks of gestation. Why has this happened? Yes sir, for certain anomalies, because sir, there was a problem where we were getting the fetal anomalies detected at 22 weeks, 23 weeks, then we were not able to do MTP. Okay, yes, but Gynae, yes, abhi aayega. Okay, so 20 to 24 weeks, this has been increased if you get some fetal anomaly, or there is a rape victim or a sexual assault victim who has fear of coming out and all that, and then we detected late. In such cases only. So when mother has a problem, when the baby has a anomaly or some genetic problem in the baby, genetic problem also certain are detected. Okay, and we are coming to it. Okay, yes, and if there's rape, assault victim or sexual assault or some special situations, okay, like the couple undergoes divorce during pregnancy or during pregnancy at around 2021, if there's a divorce happening, all that, so that is the case. Specifically for anomalies, the upper limit has been raised. Please understand, if the question is that for if I change this question and if I tell according to MTP Act of 2021 for failure of contraception, yeah, if there's a mother's life risk, of course, Elizabeth, we can do it. Risk to the mother's life, 100% we do it, na, even at 24. So all this kind. So mother life is at risk, baby is a all that we do. But can you tell me for failure of contraception, then what? Yes, for failure of contraception, it is still up to only 20 weeks. Please don't make a mistake. If your condom has failed, if your contraception has failed, you can't be sitting at home till 24 weeks. Okay, so please keep this in mind, that failure of contraception is still only up to 20 weeks of gestation. Okay, yeah, thank you Bharat, thank you, and do check in the app also, and do check in the YouTube channel also, and join the Telegram also. Yes, so keep in mind that up to 20 weeks of gestation, failure of contraception is still only up to 20 weeks of gestation. Okay, yes, extremely important, 100% sure shot. Tell me the answer. Okay, so I repeat, failure of contraception is to 20. Overall, this answer is 24. Okay. Yeah, up to 20 weeks now, only one doctor can give this. Absolutely correct. Yes. Yes, yes, yes. Chalo, anybody. So what is if up to 45 days, how do you give and what do you give? Somebody saying C, somebody saying D. Okay, so point number one, remember which drug and total confusion. And many of you are saying A, and I am telling you A is wrong. Why A is wrong? Why A is wrong? Yes, so please understand what are the two drugs do we use, how to remember. Okay, first, which drug do you give? So this is a combi kit. All of you pay attention, like this image could also come in your exam. This is a combi kit. What is this single tablet? Clap if you feel happy. How will you remember what are the two drugs? Mifepristone is the first drug and misoprostol is the second drug. Which do you give first? Which do you give first? And there is a 48 hours gap. That's why this is given on day 1. This is given on day 3 after you take the proper consent. Now clap if you feel happy. My dear students, कैसे याद रखेंगे? कैसे याद रखेंगे? मैं हूं ना. MI दोनों में सेम है. MI दोनों में है. F is first. Yes, clap if you feel happy. F I will give first. And S I will give second. Second starts with S. Yes. Yes, very good. Mifi given first, very good. F for first and S for second. Okay, so this is okay. So always mifepristone is given first, and after 48 hours, the misoprostol is given second. And all of you remember, mifepristone is a anti-progestrogen. It is anti-progestrogen. It will block the progesterone. And mifepristone is 200 milligram. 200 milligram. Okay, so all of you see this option out because I'm giving meso first. Rule out this option. Option D also out because वो दोनों में meso is written first. Meso 200 and methotrexate I don't use, and meso and then mifi I don't use. Okay, is this understood to all of you? Yes. So remember students that this is mifi, which is a single tablet, and this 4 tablets each is 200 microgram. It is a 200 microgram tablet, and you can clearly see there are 4 tablets, so it is 800 microgram. 800 microgram, and that becomes the answer. Okay, sir, mifepristone 200 milligram followed by misoprostol 800 microgram. Is this understood to all of you? Can I get 5 thumbs up? Yes. So this, why this is not the answer? Here see, we have smartly changed the unit. यहाँ पे 200 mcg कर दिया है नहीं, और 800 milligram कर दिया है. Therefore option A is wrong. Okay, so in the heat of the examination, please don't make a mistake. Yes, absolutely correct. Misoprostol is a PGE1 analog. Misoprostol which you give, misoprostol is a which type of PGE1. PGE1. Okay, PGE1 analog. Okay, is it clear to all of you? It is a PGE1 analog. Yes, so beta meso oral say better, vaginal better, because oral lot of nausea, vomiting can happen, the patient pukes. So vaginal can be given, or even even sublingual can be given. Oral can also be given. It's not that you can't give. Okay, but meso vaginal is preferred. You can put all 800 microgram vaginally. All 800 can be put vaginally. Okay. Yes. So is it clear? Because oral ka problem is that oral mein if there's nausea, vomiting, the patient will puke out the tablet, then there's a problem. Okay. Yes. Yes. Beta, not only Jimmy, Jaipur, Jackson, 99% success correct. The technical correct. The theoretical theoretical. The textbooks mention that the success is up to 96%, but you are correct. In my practice also, even up to 9 weeks, okay, up to 9 weeks also, yes, 99% success we are getting, okay, 99% success we are getting, almost 100, okay. So 99% success is we are getting it, and therefore always ultrasonography should be done. Always keep in mind. Anybody, how do I know? After you give it, always you need to repeat ultrasound, okay. Please preferably repeat ultrasonography after 14 days to make sure everything is clear, okay. Yes, perfectly correct. Very, very important. Decubitus ulcer. Can you tell me which condition do I get decubitus ulcer? No, but even in India, 9 weeks, okay. Medico, 9 weeks. Combi kit allowed up to 9 weeks. Look at the packet, okay. WHO 9 weeks, even in India, 9 weeks only. Mifi Mizo can be given up to 9 weeks. Okay, okay, Medico, I hope it's clear. Yes, give me a thumbs up. Yes, perfectly correct. So, decubitus ulcer is in which condition? Prolapse, but which degree prolapse? Which degree prolapse? Okay, yes, sir, you get it when the cervix is exposed. When the cervix is exposed, so mainly in the 3rd degree or 4th degree prolapse. 3rd degree or 4th degree prolapse. What is a decubitus ulcer? It is a circumferential ulcer, okay, around the prolapse part of the cervix, round and round. Round and round there is a ulcer which the patient gets, okay. It's a complete like a 360-degree circumferential ulcer you get around the prolapsed part of the uterus. Packing, very good. Packing with what? Packing, no laser, no antibiotics, no cryo. Normal student only knows packing. Normal student only knows packing. My student will know packing with what? Packing with what? Keep in mind, packing is done with glycerine. Clap if you have learned something new today. Glycerine and acriflavin. Glycerine is a hygroscopic agent. Glycerine is a hygroscopic agent. It will decrease the edema. And acriflavin is a yellow color dye. It is a yellow dye which will help in rapid healing and epithelialization of the ulcer. So glycerine, acriflavin is what you give, okay. Glycerine, acriflavin is what you give for packing, okay. So it's very important MCQ. It has been asked in the past, likely to be repeated in the future, okay. This was asked in the FMG. Yes. Now a image based MCQ. Image based MCQ. Beta BL, I think you must have joined late. All difficult, all the latest guidelines also we are discussing, and even clinical cases we have discussed. And paper overall FMG is going to be easy only. When all my students will find it very easy only. Yes. What is this instrument? What is this instrument? Device, first identify the instrument and it is least likely to be used for which condition? Yes. So this is a uterine sound. A, wrong, wrong, wrong. Okay. Yeah, BL, tell me the answer. Yes. Okay, perfectly correct. So this is a uterine sound. What is it used to measure? Uterine sound is used to measure uterocervical length. Uterocervical length. And please Pay attention, please. Yeah, beta, we discussed BL. We discussed clinical cases also. We have already discussed. You go and see the video. I think you joined now. Already clinical cases are being discussed and more clinical cases are going to be discussed. Don't worry. Okay. Yes. So now all of you, device least likely to be used. Please understand the question is least likely. Least out of the 4 options. So uterine sound, I am going to measure the uterocervical length. And why do I measure the uterocervical length? So that we don't perforate the uterus. Okay, so we measure the uterocervical length so that I know how much instrument I have to put in inside. Okay, if the UCL is this much 4-5 centimeter, you can't put the instrument excessive. So for anything, any intracavitatory procedure, okay, yes, intracavitatory procedure, any procedure which we are doing within the cavity of the uterus, like suction evacuation. So when do I measure? For DNC, MTP, MVA, suction evacuation, all these conditions, I have to, and also for IUCD insertion. The question over here is least likely. Array, removing the IUCD. Okay, removing the IUCD is with what? Why for removal will I require a sound? Removal is with what, all of you? Sir, when I want to remove the IUCD, I am not entering inside the uterus just with the help of the threads. Yes, just with the help of the threads, I am going to hold it with the artery forceps and remove the IUCD out. Okay, so artery for the remove the IUCD with just holding the threads you will pull with the artery forceps or whatever, and there I am not going to sound the uterus. Is this clap if you have learned something new? So the device is least likely. DNC, suction evacuation, insertion, yes, of course we are going to definitely require to use the sound, and risk of UCL perforation should be there. Removing the IUCD does not require the sound. Okay, this was again asked in the this. See, when you know the concept, they will tell you this. The same thing can come. Patient has come to you. I can, okay, 45-year-old, para 3, living 3, comes to you with post-coital bleeding. This becomes a clinical case. Okay, student. So how, once you know the hashtag crystal clear concept, any MCQ in the world you can answer. So this is a clinical case. 45-year-old came to us with post-coital bleeding. You want to do the colposcopy and cervical biopsy. We want to do colposcopy and cervical biopsy for the patient. Which filter will I use for this? Yes, this is a previous year question. Very good, Ashwini Yadav. The answer is green filter. And can you tell me why green filter? Green filter is for what? Green filter is for what? Green filter is to see what better. Anybody? Green filter से क्या better दिखेगा? Green filter is to see the blood vessels. Because as a physics principle, you don't have to remember the detail, but the blood vessels are seen better with green color filter. Okay, is this understood to all of you? So green filter, keep in mind, green filter is to see the blood vessels, because any cancer there is neovascularization. Nobody told me green, everybody telling me green filter, but for what? Yes, now say yes, for blood vessels. Okay, is it clear to all of you? So green filter is for blood vessels. Okay. Yes, again a clinical case. Patient had infertility, very simple. Again, ovulation induction agent was used, and identify, because these are very likely to be repeated. That's why I've selected. Okay, anybody? What is this image? Yes, all of you should get it correct. We are seeing, okay, so what is this? Yes, so this is your OHSS, where specifically, and can you tell me two things? Which ovulation, and why not A? Anybody, why not PCOS? Why not PCOS also I will tell you. Anybody? Yes, OHS is correct. Absolutely agree with all of you. Anybody? I'll tell you. And which ovulation induction agents? Which ovulation induction agents likely to cause this scenario? Okay. Yes, very good. Elizabeth, Jimmy, Jackson, all of it. Okay, so here's the specifically if HMG injection is used or recombinant FSH. When HMG or recombinant FSH is used, there is a chance of having multiple follicles, and OHSS specifically happens when finally we use HCG. HCG is given as a trigger. Actually, along with this this is just like a stimulated ovary. Okay, this is a big stimulated ovary, and we are seeing multiple big follicles, multiple big follicles all coming in the center also. Along with this, we should also see actually free fluid and ascites. Okay, free fluid ascites should also be seen. Okay, that is the feature of actually ascites should be shown to you also. So keep in mind, yes. Okay, and how will it differ is that PCOS will have multiple small follicles. Okay, so in PCOS the follicles are small and arranged in the periphery. Very good, keep that in mind. So multiple small follicles and arranged in the periphery, that is your PCOS. And when you see big follicle coming in the center part also, but remember in the exam they show you only this one picture which is actually incomplete. They should also show you a picture of this plus ascites, because free fluid in the pelvis, then that is, yes, this is the necklace of pearl pattern PCOS. Okay, string of pearls or necklace of, okay, so don't get confused, perfectly correct. This is ovarian hyperstimulation syndrome. Okay, so PCOS में multiple small है, and here patient is showing big follicle. Yes, because of hyperstimulation. Okay, details will listen. Yes, again a very important absolute contraindication for IUCD is which of the following is an absolute contraindication for IUCD? Yes. So remember students that when there is a past history of a PID, it is not a absolute. Acute PID, acute pelvic inflammatory disease, that means any active focus of infection becomes the absolute contraindication. Okay, then menorrhagia patients, you avoid putting a copper T, but of course your Mirena can be put in. Menorrhagia patient is a relative, not a menorrhagia dysmenorrhea becomes both our, yes, becomes our both relative contraindication. And ectopic, anybody, what is the connection between ectopic and IUCD? Will very common confusion among the students, I'll clear it. Will if I tell you this sentence, okay, IUCD increases ectopic pregnancy, true or false? True or false? Yes, if I tell you IUCD increases ectopic, wherever you have read that, Yes, put this kachra dustbin. IUCD does not increase risk of ectopic pregnancy. Okay, unnecessary IUCD has been blamed. If IUCD, very good, excellent, all of you. Okay, yes, because IUCD will prevent pregnancy, IUCD will also prevent ectopic pregnancy. But if IUCD is not LNG IUD protective, yes, we already discussed LNG IUD protective. Okay, LNG IUD protective for ectopic. Okay, but IUCD does not increase the risk of ectopic if inserted with all the aseptic precaution. But if IUCD you have not inserted properly and then there is infection, then the PID can cause more ectopic. Okay, PID definitely, pelvic inflammatory disease, increase ectopic. IUCD failure, yes, remember students. Okay, IUCD failure. Very good, Shivangi Sharma, perfectly well summarized. Okay, IUCD failure means if the patient has conceived, if the patient has conceived, and with the property in place, then IUCD failure may there is an increased risk of ectopic pregnancy. Okay, is this understood to all of you? So past history of ectopic pregnancy again is not a contraindication. Okay, beta जिसने पूछा option A नहीं होगा, past history of PID है ना, so it becomes a relative contraindication. Past history, not acute PID. Okay, answer is undiagnosed vaginal bleeding. Okay, undiagnosed vaginal bleeding, undiagnosed vaginal bleeding is the undiagnosed vaginal bleeding is the answer, where till my diagnosis is not made, absolutely contraindication. Yes, IUD perfect. Yes. Okay. So can anybody tell me three more absolute contraindications for IUCD? Acute. So just remember, for my acute PID, just a second. For absolute contraindications for IUCD, acute PID, puerperal sepsis. Okay, puerperal sepsis, and yes, of course, pregnancy, undiagnosed bleeding. Okay, and following vesicular mole, because after vesicular mole evacuation, yes, following vesicular mole cancers, okay, CA cervix, CA endometrium, V mole evacuation, and uterine anomalies. There are two separate horns. Then how will I put the IUCD? Okay, so a lot of extra information we are giving you. So undiagnosed vaginal bleeding is the absolute contraindication for ectopic for our IUCD insertion. Yes. Anybody? Yes. Again, very 19-year-old unmarried girl for MTP at 10 weeks. Chalo, clinical case. Somebody was asking me, sir, give me a clinical case. So सब कुछ आएगा. Okay. Clinical case will come. Image will come. Yes. But adenomyosis you can, not a problem. Okay, Arakdeep, adenomyosis is your within the mountain. So patient has menorrhagia, so we can try to use LNG IUD, not a problem. Septate may yes not. Yeah, current STIs, beta mega. Current STIs, correct. Acute sexually transmitted. Yes. So how many for option number D? How many for option number D? Inform the police. Inform local police station. No. Why? Just because she is unmarried girl does not mean she can't have sex. Okay, as long as the girl is above 18 years of age. If the same patient was 16 years, 17 years, then yes, I have to inform the police, but then still MTP is not contraindicated. Is it clear? MTP can be done. MTP can be done. Anybody, why is option A not the answer? Option A is only up to 9 weeks. Me-fi, meso, we just now discussed. Me-fi, meso is only up to 9 weeks. Best up to 7, but up to 9 weeks I can go. Patient is 10 weeks pregnant, and therefore option number 2 is the answer. MVA or suction evacuation we can do up to 12 weeks. Yes. Okay. Okay, so POSCO Act, correct, Ashwin Yadav. Okay, sir, if the girl is 16, 17, even with consensual sex, you have to inform the local police station. But still remember, MTP is not contraindicated. Okay, MTP you will do for that girl. You inform the police and then do MTP. Okay, and this ethacridine lactate is again outdated kachra that was being used for second trimester. So I hope all these questions will helpful to you. So if the question is instead of this 10 weeks, if the question is 6 weeks, 7 weeks, then mark Mifi-Meso as the answer. Okay, Mifi-Meso will be the answer preferred if the question is 6 to 7 weeks, because why do a surgery? When the patient is 10 weeks pregnant, MVA or manual vacuum aspiration or suction evacuation becomes the answer. Okay. Yes, very, very simple, but it has been asked so many times that I have to teach you this. Grayish, white discharge and positive whiff test. All of you should get it correct. Anybody, what is this condition? Yeah, more than 12 weeks, correct. Yes, that's her positive whiff test and grayish white discharge is seen in a patient of bacterial vaginosis. Okay, BV. Okay, bacterial vaginosis or bacterial vaginosis. All of you correct. And drug of choice is metronidazole. Can anybody tell me what is the whiff test? What is the whiff test? What you do in whiff test? We take the MV up to 12 weeks. Yes, Ronak Patel, correct. Correct. Okay, metronidazole is the drug of choice. Perfectly correct. Anybody? Fluconazole is for which infection? Fluconazole is for which infection? Fluconazole we give for fungal candidiasis. Okay, metronidazole is the answer, and in that, yes, we will take the secretions, vaginal secretions, and we will add 10% KOH and we will get, okay, this we get a fishy odor. Okay, fishy odor you get. This is a positive whiff test. And another which very important thing which you need to keep in mind is the clue cells. Clue cells you also get in the same condition, bacterial vaginosis. Okay, image, this one. Okay, yeah. So anybody, one second, huh? Yes, laparoscopy chromopertubation. Already discussed today. What is the test for laparoscopy chromopertubation? Is a test for what? And here what do we use? Laparoscopy chromoperturbation is the best investigation for tubal patency. Tubal patency, and here blue color dye, methylene blue. Very good. And everybody start jumping in the OT. Okay, blue hai pani. Okay, blue color dye we put into the cervix. Okay, a blue color dye is pushed into the cervix. We are putting in a laparoscope and we are seeing whether that blue color dye will come out. Where do we put the dye? The dye is put into the cervix. Okay, so when you push the dye into the cervix, the dye will enter here, and the dye will fall in the pelvis if the tube is patent. That's also called the spill of the dye, and that is laparoscopy chromoperturbation, best investigation for tubal patency. Again, this has been asked in the past. Don't make a mistake. Methylene blue is the answer. Clinical case. Some student wanted a clinical case. Chalo, aa gaya. Both 2 in 1. Image also and a clinical case also. Yes. Anybody, what is this? What is this? Yes, very, very simple. Please don't make a mistake. Very simple. This is a 15-year-old girl, cyclical abdominal pain, primary amenorrhea. Please tell me why urinary retention. Why patient has urinary retention? Okay, so this is, now can anybody tell me, this is a topic of cryptomenorrhea basically. Okay, cryptomenorrhea, anybody, can you tell me under image? Yes sir, image is telling you it is a imperforate hymen. Image is telling you it is a imperforate hymen. And what is the treatment? Cruciate incision. Cruciate incision you will put. Cruciate incision you will put. Okay, not incision and drainage, don't say and yes, but cruciate incision is what is done. Okay, now out of the yes, so bluish bulging hymen, when you get that in the question paper, when you get this in the question paper, that there is a tense bulging hymen. Okay, you get a tense bulging hymen, bluish in color. Okay, bluish purplish color hymen. Then yes, because sir, the blood is getting accumulated. Very good, all of you. The menses will start, but the blood is not able to come out. So the blood will get collected inside the vagina, called as hematocolpos. This hematocolpos will uh, will press the bladder and there is urinary retention episode. So when they say cyclical abdominal pain with primary amenorrhea, think of this. Can anybody tell me in the question paper, if this picture is not given to you, if this image is not given to you, two options are possible. Anybody, which are those? Suppose the image is not given to you, then which two answers are possible with the same MCQ? Yeah, Leach Wilkinson, you can use urograph. That's not yes, no problem. In laparoscopy chromoperturbation, you use always methylene blue. Yes, very good. Transverse vaginal septum also. Transverse vaginal septum and imperforate hymen. Why not longitudinal vaginal septum? Because sir, when there is a transverse vaginal septum, it is going to block. Okay, longitudinal vaginal septum में the blood can come out. Longitudinal septum अगर है, so then the menstrual blood will come out. There is no blockage. So cryptomenorrhea means always outflow obstruction. That is cryptomenorrhea. Okay, but of course, since this image is there with us, we have to mark imperforate hymen as the answer, and cruciate incision. So remember hematocolpus, hematometra, all that you need to keep in mind. Yes. Okay, now please pay attention. Yes, again a clinical based question. Okay, so all types of questions I'm teaching you. Okay, yes, chalo, longest question, clinical based question. Yes, correct, medico. Transverse vaginal septum, no bulging hymen, and here you get bulging hymen. Okay. Yes. So the patient is discussing about when should you remove the vaginal diaphragm. Don't remove it immediately. There is increased risk of failure. Overall this vaginal diaphragm has got lot of failure anyways. And maximum how much time? Max how much time can you keep the vaginal diaphragm? Yes, perfectly correct. After 6 to 8 hours, 6 to 8 hours के बाद निकालना होता है. Wait at least for 6 to 8 hours. And no, it's a barrier method. Okay, Akib, it's not a, yes, correct. If you max, we keep it only for 24 hours, because if you keep more than 24 hours, there is a risk of toxic shock syndrome. So it's not a foreign body reaction. It is a barrier method. Okay, it is a barrier method. If this is the vagina, this is the cervix, this is the uterus, the diaphragm will be somewhere over here. Diaphragm is placed over here. Okay, yes, all of you, diaphragm is over here. This is the vaginal diaphragm. It vaginal diaphragm covers the cervical opening, okay. Yeah, better Dr. Khan, because the traditionally it is said that after 6 to 8 hours you can remove it. Okay, if the question is maximum till when can you keep, okay, then maximum up to 24 hours, but never beyond 24 hours. So never after 24 hours. Okay, after 24 hours there's a risk of all of you telling in that chat box. Perfectly correct. Toxic shock syndrome. Perfectly correct. Okay, yes. Clinical case again. Yes, yes. Okay, so yes, I hope you are here, beta was asking. Okay, so all the clinical cases are also coming. Chalo, we have a patient, 48-year-old parathletic living with the longest question. Please read. So back to back, lot of clinical questions also we have discussed. So every type of question I have tried to cover. I've tried to cover gynae, obstetrics. I've tried to cover clinical, one-liners, images, all types of possible questions. Whatever best I can do, I'm trying to cover. Yes, anybody? Very, very important. Patient has come to us with heavy menstrual bleeding, endometrial aspiration, or cytal, or this biopsy showing endometrial hypoplasia with atypia, which is the most appropriate management. Yes, very good. So please understand this. Can anybody tell me, because the family is already complete and she is a old patient, and most importantly there is hyperplasia with atypia. Hyperplasia with atypia, progesterone will not act. Progesterone acts very well. LNG IUD is our Mirena. Mirena or LNG IUD works very well in this condition if there is no atypia. If there is no atypia mentioned, and if it is a young patient. Okay, my dear students, if it's a young patient, okay, C नहीं है आंसर बेटा जमाल. Okay, C आंसर इसका नहीं है. I'm explaining you बेटा. Okay, yes. So when, yes, A है आंसर. Correct. Very good Jamal. Correct. Tasur Jamal. Yes. So Mirena is effective if there is no atypia present, and specifically in young patients when I want to preserve the uterus. So if the same question instead of 48 years old is 25-year-old, and if they tell you no atypia, then definitely LNG IUD can be used. OC pills we don't give. And please understand student, even if atypia is present, you have to do only a simple hysterectomy. Sir, family is complete, and also family is complete, that's one thing. And the other thing is that there is atypia present, so you don't want to. Yeah, yes. Okay, so to preserve the uterus in a young patient, we prefer to use progesterone. So all of you keep this point in mind, that when it is hyperplasia in a young patient, then what do we prefer? We prefer progesterone. Okay, and then then when there is hyperplasia in a old patient, then simple hysterectomy. Simple hysterectomy. Okay. Is it clear? Is it clear to all of you? Simple hysterectomy is answer. No. Anybody, when do I do this Verdham hysterectomy for? Verdham hysterectomy is for what? Verdham hysterectomy is for which condition? Okay, so keep this rule in mind. Yes, not only yes, Verdham hysterectomy, my dear students, is mainly for cancer. And there's actual cancer, CA cervix also, cervical cancer also, and even in CA endometrium, we use Verdham hysterectomy. Early cervical cancer, there's actual cancer. Remember, TPI, if it's present, don't mark this, okay? So Verdham hysterectomy is for actual cancer. So here only simple hysterectomy is enough, even though it's hyperplasia with TPI, because it is not yet cancer, it may become cancer. Okay. Yes, cervical cancer up to stage 1A to 1B up to 2A, we can use it. Okay. Yes. So clinical question also discussed. Again, a clinical question. I wish that student was there. जो student था वो there asking me. Okay. हाँ बेटा, वाकत अली, हिंदी में तो बेटा हम तो पूरा लेक्चर हिंदी में ले सकते हैं. ओके बेटा, इतना बढ़िया हिंदी में सिखाएंगे ना. लेकिन प्रॉब्लम क्या है कि मेजॉरिटी स्टूडेंट जैसे कि सर प्लीज यूज इंग्लिश ओनली, सो आई कैन यूज बोथ. यस, डोंट वरी, थोड़ा हिंदी, पूरा हिंदी में भी पढ़ा देंगे, डोंट वरी. हाँ बेटा, तसुर जमाल मेरे से ही पढ़ना है डेफिनेटली. सो बेटा ये नोट डाउन, जस्ट नोट डाउन दिस वेबसाइट. आई एम ऑल्सो गोइंग टू शो यू अ फोटोग्राफ ऑफ दिस. अभी मेरा एक लिंक स्टार्टिंग में मैंने दिया था. आप ये व्हाट यू कॉल्ड, just install the app also, and please subscribe to the app also, and you will love the lecture is my guarantee. सब कुछ आ जाएगा उसमें. Yeah, don't worry, English will only come, don't worry. Okay, so just you can do this. Okay, so I'll just share you the link also of the YouTube channel also, Jamal, and all of you can also subscribe to the app. You will just love the videos also. Yes, so again a clinical case. Chalo, we have got a patient who has come to us at 32 weeks, and we have found out that on ultrasonography it is 29 weeks. So what is it telling you? What is this diagnosis? Yes, sir, there is a lag. Yes, sir, patient is 32 weeks, but the baby has grown only up to 29 weeks. IUGR. IUGR. Thank you, thank you. Okay, yes. So IUGR, what are the causes? Yes, except. So this is how the students make a mistake. That sir, hypertensive disorders, preeclampsia, eclampsia will cause IUGR. Placental infarcts, any infection, all can cause IUGR. Uteroplacental insufficiency can cause IUGR. Yes, the answer is diabetes. In diabetes, what do we get, my dear students? Sir, in diabetes you get big baby, macrosomy. Okay, diabetes is going to be a big baby, macrosomy we get. Okay, in diabetes. That would have been ulta. If they tell you patient is 32 weeks and on sonography the baby is appearing 34 weeks or more, then you have to mark gestational diabetes. Okay, because diabetes is going to cause macrosomy. Yes, perfectly correct, all of you. Yes. Okay, now again a clinical case scenario. Again a clinical case scenario that a patient has come to us with 3 abortions and also a Doppler revealing thrombus in the deep vein. Okay, what is this? And also all the abortion were less than 12 weeks. What is this condition? Anybody? Yes. Okay, sir, this is Anybody? Yes. So this is a thrombophilia patient. Remember 3-4 features of thrombophilia. Just a minute. I need a blank slide. Give me, yes. So whenever, okay, thrombophilia, thrombophilia or antiphospholipid antibody syndrome. Okay, thrombophilia or antiphospholipid antibody syndrome, where there is a hypercoagulable stage. And what all obstetric complications can happen? Yes, sir. Repeated abortions. Okay, patient will have risk of repeated abortions. Also risk of developing severe preeclampsia. Severe preeclampsia and severe IUGR. Okay, is it clear? Okay. Yes, Kushal, correct. Yes, these are the question for NEET PG also. There is also NEET PG previous year. Okay, yes. So please keep in mind that here, and also DVT, okay, deep vein thrombosis. So this is antiphospholipid antibody syndrome, and treatment is by what do you give treatment for? What do you give the treatment? We give for treatment antiphospholipid antibody syndrome, and we give low molecular weight heparin. LMWH is the main treatment along with aspirin, but low molecular weight heparin is we should give. Okay, so antiphospholipid antibody syndrome, low molecular weight heparin, because multiple abortions in the first trimester and plus DVT thrombosis, that is the this. Okay, yes. Now, which all of the following can be used for emergency contraception except anybody except Jimmy Jaipur Jackson? Warfarin we don't use in pregnancy. Warfarin we avoid in pregnancy. Warfarin is given only when there is a metallic valves. Okay, okay, Jimmy. When there is metallic valves in the body, then you prefer to give warfarin. Okay. Yes, sir. Emergency contraception में we can use LNG, ulipristal, IUCD, but not misoprostol. Misoprostol is for MTP. It is for MTP. Okay. Yes, medical termination of pregnancy. I just now told you we give misoprostol. And emergency contraception is not, pregnancy is not confirmed. When the patient is pregnant, when the patient pregnant is there, when the patient is pregnant, then we can go for MTP, then we can use misoprostol. Okay, so emergency contraception is to prevent pregnancy. Yes, and this is also going to be asked to you the same thing. Next, very important. Next, very important. Chalo, because somebody, yes, which can be used up to 5 days. Okay, which can be used up to 5 days. Yes, please remember selective. This is surely coming, selective progesterone receptor modulator. This is ulipristal. This is ulipristal. It's a new drug. All of you correct. 30 milligram. Please remember the dose also. Selective progesterone receptor modulator can be used up to 5 days, and other even IUCD can be used up to 5 days. Okay, up to 5 days. LNG is your brand name IPL is only up to 72 hours. Okay, only up to 72 hours. Okay, only up to 72 hours. Misoprostol is not the answer. Okay, yes. Again, a very important MCQ. Again, a very, very important question. Yeah, so I hope Dr. BL, you were there. Okay, so many clinical questions in between we had discussed, back to back, 3-4 clinical questions we had discussed. Yes. Yeah, all these are combination of previous year's questions, and all these are combinations of the upcoming exam questions. But no, Annu Moyal, Ulipristal is up to 5 days. Okay, please keep in mind. LNG is up to 70 dollars. Ulipristal can be used up to 5 days. Okay, so please don't don't make a confusion. Ulipristal is a newer one. Yes, what is this? So artificial insemination with husband is another name for IUI, intrauterine insemination. Yes. Now what is done in IUI is perfectly correct. All of you please pay attention. In IUI, the semen sample is taken and we bypass the cervix. We bypass the cervix. It is one of the main treatments for male factor infertility. So what is done in IUI is that we take the semen sample of the male in the laboratory, I wash it, all the kachra I remove, all the lula langda sperms, all the dead sperms, all the faltu sperms are removed, and then we put the washed semen inside the uterus. That is IUI. But now is the important point. From here the sperms have to go above on their own. Even the egg has to come from here. So for IUI to be successful, my fallopian tube, my means the patient fallopian tube, should be patent. All of you look on the board. If the fallopian tube is blocked over here, if the fallopian tube is blocked over here, then IUI cannot be done. IUI should not be done. Is it understood to all of you? So when husband has a count of 9 million per ml, yes sir, the count is low, so we can use IUI. Anti-sperm antibody in the cervical mucus, also IUI helps because we are bypassing the cervix, isn't it? I am bypassing the cervix and putting the sperms inside the uterus. Yes, all of you correct. And even in impotency, when the husband is not getting erection, you can tell him that for erectile dysfunction we can give him sildenafil, Viagra, all that. But still, if the husband is not getting the erection, then you can try IUI. Okay, yes, azoospermia is completely zero sperm count. Somebody said no semen. No, absent semen nahi hai beta. Jimmy, absent semen is what? So azoospermia matlab zero sperm count. Okay, zero count. So here either we have to go for IVF or we have to go for IUI, but IUI donor. All of you know that Wiki Donor movie had come. Okay, so IUI donor will have to be required. Yes, correct. So less than 16 million, correct, latest. Okay, so azoospermia is the answer, because in azoospermia there is zero count, so IUI husband is not possible. Okay, so I hope all of you are liking it and loving it. Yes, somebody was asking me, see आपने बोला मेरे पहले से ही क्वेश्चन रेडी था, Kalman syndrome sir हमको बताना. Somebody was telling me, Sheehan syndrome, tell me. So which of the following is a hypothalamic cause of primary amenorrhea? Yes, anybody? Which is where hypothalamus is a problem? Anybody? Yes. So point number one, Turner's syndrome, what it is? Sir, all of us know Turner's syndrome is streak ovaries. So here ovary, gonadal dysgenesis. Turner's syndrome overall, you know, gonadal dysgenesis. So gonads is a problem. RMKH is your absent uterus. We discussed this today only. Uterus is absent, and perfectly correct. We are discussing beta Elizabeth. Okay. Yes. Kalman syndrome is the answer, because what is happening in Kalman syndrome? Kalman syndrome is GnRH deficiency, and GnRH comes from hypothalamus. Okay, GnRH comes from hypothalamus, and GnRH deficiency along with what happens? Sense of smell is gone. Anosmia. Okay, so GnRH deficiency, and GnRH is coming from hypothalamus, so it is a hypothalamic cause. Very good, Annu Moyal. Okay, sir, Sheehan syndrome is, first of all, hypothalamus is not the problem, and Sheehan syndrome always will have secondary amenorrhea. Why secondary amenorrhea in Sheehan syndrome? Yes, Calvin gene, perfect, correct. Okay, yes, there is Sheehan syndrome is postpartum pituitary necrosis. How will the question come in this? Yes, postpartum pituitary necrosis. So they will tell you that the patient was having PPH. During delivery, the lady has PPH, postpartum hemorrhage. During delivery, the patient is having postpartum hemorrhage, and with the postpartum hemorrhage, after postpartum hemorrhage, there is, yes, failure to lactate. Perfectly correct, ZV. Okay, that there is, they tell you that patient amenorrhea persists and failure to lactate, that is the earliest. Okay, also called as agalactoria. Okay, agalactoria. So that is Sheehan syndrome, and that is secondary in secondary amenorrhea. Okay, not cancer. Okay, so Kalman syndrome is the answer because deficiency of GnRH along with, so GnRH deficiency hoga, so FSH-LH, yes, so it's hypogonadotropic hypogonadism. Yes. So again, one more request, all of you, those who have been asking me, please, all of you, click a screenshot of this. Please click a photo. This is the newly launched YouTube channel of OG Guru, and also Telegram channel is there. So all of you can be in touch with me even after the session is over. So quickly, 5 seconds, please, all of you can click a photo or have a screenshot of this, and all of you, please do subscribe to the channel right away after or even while the lecture is on, or it will just take a minute. So this is the YouTube channel and this is the Telegram channel. Okay, so quickly, all of you do subscribe to the channel, and please request to spread across the word and tell all your friends and colleagues who are not even here. Tell them about this video lecture streaming, and also tell them about this YouTube channel so they can subscribe and join. Okay, so I hope all of you have noted down. Beta, even, yes, correct. Okay, yes, again a very important, chalo, this is your match the column kind of a question. Match the column kind of a question. Yeah, I will. Yes, chalo. Anybody? What is in Burns-Marshall maneuver? Where do you use Burns-Marshall? Okay, Burns-Marshall is for after coming head of the breach. In after coming head, it means after coming head of breach. Okay, in after coming head of the breach, please remember this Burns-Marshall maneuver. So one is going with C. Okay, so one is going with C, so only 1 and 4 are possible. 2 is out, 3 is out. Anybody? Wood's maneuver. Wood's maneuver is for shoulder dystocia. New word, not routinely asked. Please remember, will come in the, it's a virgin MCQ. Wood's maneuver is for shoulder dystocia. Majority students know for shoulder dystocia which maneuver? Mac-Roberts maneuver. Okay, Mac-Robert is a more commonly done maneuver. Mac-Roberts maneuver, all of you compulsory have to by heart. Mac-Robert is mainly for shoulder dystocia, but Woods is also for shoulder dystocia. So 2 is going with F. Yes, 1C, 2F, and therefore all of you know the answer. And what is this cuvular uterus? Sir, cuvular uterus you get in which condition? Cuvular uterus we get it in abruption, and the blood goes retrograde. Okay, yes, and McAfee and Johnson. Yeah, thank you. Okay, McAfee and Johnson. McAfee and Johnson is a conservative management. McAfee and Johnson is a conservative management which we do in placenta previa. Placenta previa. Yes, perfectly correct. Okay. Okay, so McAfee and Johnson is the this. So we have now 1C, 2F, 3A, 4B. Okay, 3A, 4B, that is the perfect answer. Coiletrus and McAfee Johnson for placenta previa. So 1C, 2F, 3A, 4B. Okay, and all of you also attempt the mock test. Okay, the app is, the link is over here, OG Guru app, and please attempt a mock test also. Okay, there's a mock test for OBGY, very nice question. So it's a free test, free for all. Okay, free mock test in OBGY. Okay, so all of you can install the app also, and please attempt the test also. Okay, free mock test, completely free, very nice clinical questions, image based questions are there. So all of you can just install the OG Guru app, and you can just attempt the free test also. Okay, yes, so more practice MCQs are there in this. Yes, again, chalo, yes, somebody wanted PPH. See, you are asking me, I am giving you on demand. Okay, yes, PPH, what is this and which type of PPH is there over here? Anybody? Beta Medico, you can just go on this website. Can you see over here, ogguru.app? So there's a new app which we have done, and there you can just install this. Okay. Okay, Medico, just a free. Okay, so just go to the. Okay. Yes, yes. Of course, solution will be there, beta. Okay, solution will be there. I'll give you solution, of course. Okay. Yes. So जिमी जयपुर ज्यादा, उससे भी ज्यादा लॉस ऑफ फीटल मूवमेंट इज नॉट की फॉर अब्रप्शन. ओके बेटा, लॉस ऑफ फीटल मूवमेंट्स मींस इट कुड बी आईयूएफडी. फॉर अब्रप्शन इट इज मोर टोनिकली कॉन्ट्रैक्टेड यूट्रस. ओके जिमी, क्लैप इफ यू अप्रिशिएट दिस. के उसमें इन अब्रप्शन विल गेट मोस्टली टोनिकली कॉन्ट्रैक्टेड यूट्रस. बेटा सेम. ओके ऋतिक, थैंक यू फॉर आस्किंग दैट. This is the name of the app, and you can go and this beta, yes, it is right now. iOS also coming very soon, Vicky. iOS also coming right now, just it has been launched for Android. iOS will be coming in the next 10-15 days, hopefully very very soon. Okay, so iOS also coming, but this is the app for this. Okay, yes. Okay, yes. So now this is a atonic PPH. It is a atonic PPH where the woman placenta starts to bleed and cervix is healthy, and it is uterus is flabby. Flabby means uterus is not well contracted. Uterus is flabby. So again, arey beta, Dr. Khan and Vikram Yadav, you didn't read. Yes, all except, yes. So please see, this is how the students are making mistake. Okay, so all except I can use for atonic PPH what it is. Yes. Okay, yes, there is a disc, everything is there. Okay, let's, yes. Okay, Thank you, Ajali, Pius, thank you. Okay, so chalo, the question, yes, very good, sir. Oxytocin is the first drug of choice. Oxytocin is the first drug of choice. Misoprostol can also be used in a tonic PPH. And what is this new drug? Carbetocin. Absolutely new. All these recent advances you are going to learn. Yes, now all of you got it correct. The answer is mifepristone. So my dear students, this is an easy MCQ. You don't read the question in the exam, and that is when you lose the marks. So please read it question correctly. This is that all are used in atonic PPH except, so yes, we need to make the uterus contract. So atonic, I have to give a uterotonic agent. Uterotonic agent is to be given. Okay. uh, Meso beta in this case, Jimmy, 800 microgram, not 100. Okay, Jimmy, 800 microgram only you give. Yes, carbetocin is a new drug and therefore it's a recent advances. It is a analog of oxytocin only. It is a synthetic oxytocin analog but stable at room temperature. Okay, it is a heat stable variety. So it will be stable at room temperature. Okay, so mifepristone has nothing to do with if with atonic PPH. Mifi, all of us, we have already discussed, it is for MTP, medical termination of pregnancy. Okay. Yeah, carbetocin, but I'm telling you, carbetocin is what? Carbetocin is a heat stable. It is stable at room temperature. Okay, stable at room temperature. Yes. Now anybody. Okay, so before that, because Barad has been asking for NT scan for a long time, so I'll just tell you, in the NT scan you just have to remember one thing, that what is NT nuchal translucency. Okay, nuchal translucency, and it is for which condition? Okay, it is for, no, carboprost different, dinoprost different. Both carboprost is also be, yes. So yes. So nuchal translucency, it is for trisomy 21. Okay, it's a fabulous entire 1 hour, 1.5 hour lecture is there. Okay, on trisomy 21 detection. You will love it. Okay, so anybody, what we do in NT is that nuchal translucency. That's this. If this is the baby, if this is the baby, at the nape of the neck of the, and this is the baby like this, so at the nape of the neck there is some translucent space. Yes, not NTD beta. Okay, not new. Yes, yes. So at the nape of the neck you have to put a caliper here, you have to put a caliper here and measure this translucent space. Okay, Bharat. So this is NT, and up to 3 millimeter, yeah, some say 3.5, some say 3, but up to 3 millimeter is considered normal. And yeah, Dr. Sam, I agree with you, 3.5 also fine. And if it is more than that, then it's a chance that the baby may have Down syndrome. So increase in NT at your level, remember, increase NT is a feature of, increase NT is a feature of your Down syndrome. Okay, so just measure this translucent space, and remember it should be like 1 millimeter, 1.5 millimeter. All that is considered normal. All that is considered normal. Okay, is it clear to all of you? Carboprost will be IM. Yes. Elizabeth Joshi, perfect. 11 to 13 weeks, perfectly correct. Okay. Yes. Chalo. Now again a clinical case. And what is the diagnosis, all of you? Clinical case. And I want the diagnosis first. XYZ, 2 months amenorrhea, uterus showing pseudo sac. Very difficult MCQ. Virgin MCQ for FMG exam and also for NEET PG. Okay, so Leah and Raju, can you better your answer? Jimmy Jaipur, answer ectopic. Can you better your answer? Yes. So look at the pulse 80, BP 120, 80, hemoglobin 11. So ectopic, yes. Ruptured or should I write it as ruptured ectopic pregnancy? Is it ruptured ectopic pregnancy? Everybody agreed? All of you, ruptured ectopic pregnancy लिख देंगे. Diagnosis. Should I give ruptured ectopic as a diagnosis? Yes, now all of you, it is unruptured ectopic. So ectopic, very happy, all of you, those who got ectopic correct, and unruptured ectopic, because sir, in ruptured ectopic pregnancy, the patient goes in shock. The patient will be in shock. Okay, this will not be there. Pulse will be 110, BP will be 90 by 60. Okay, and hemoglobin will be 7-8. Beta Chauhan Dharti. No beta. We should repeat beta HCG after 48 hours. That is when there is confirmation is not there. Here already you have made the diagnosis. What is this? Right-sided adnexial mass. What is this? 2.5 into 3 centimeter mass. So here you don't wait. Okay. Okay. Dharti beta. Okay. Is it clear? Chauhan Dharti. Is it clear? That when you do that repeating and doubling time, when nothing is seen inside the uterus also, when the beta HCG is positive, and if you get uterus is empty, okay, and nothing is seen, uterus inside also nothing seen, outside also nothing seen. That means when the diagnosis is not confirmed, okay, then in such cases you will repeat beta HCG after 48 hours. Okay, here clearly we are seeing uterus is showing a pseudo-sac. Pseudo-sac is a sign of ectopic pregnancy. Pseudo-sac is a thin walled irregular sac which you see inside the uterus. Okay, so that is, and here clearly they have clearly said in the question that we are seeing a adnexial mass which is 2.5 into 3 centimeter. Yes, and beta HCG. So no need, you cannot repeat USG after 2 weeks. What will happen? So that bomb blast will happen. In 2 weeks time, the ectopic pregnancy will rupture. Again, wait and watch. You will have to go to jail. Ectopic will rupture. Okay, you'll have to go to jail. Perfectly correct. Okay, yes, and laparoscopy surgery or laparotomy surgery I should avoid, and very good, methotrexate is the answer. Perfectly correct, because there's a MCQ coming up also. Okay, all the criteria for methotrexate are being satisfied. Okay, sir, it's a less than it's a 2.5 to 3 centimeter. It's a unruptured ectopic, and only in unruptured ectopic and HCG levels of 1500, less than 1 beta of 1500, I can definitely give methotrexate. And after giving methotrexate, how do I know my treatment is working or not? So methotrexate is the answer. Yes, all of you, because this is unruptured ectopic pregnancy and a stable patient. And after giving methotrexate, we will check the HCG level. HCG should keep on decreasing. Okay, is it clear to all of you? So repeat, you don't USG after 2 weeks. Beta HCG repeat after 48 hours is done when we are not. Yes, correct. That's sir, when the HCG levels are very low initially and we are not seeing anything inside the uterus also and outside the uterus also, then we go for beta HCG. Yes, and after methotrexate we again check the HCG levels. Perfectly correct, all of you. HCG should keep on becoming less. So clearly, okay, clearly, please pay attention. Clearly, The answer is methotrexate, and surgery I should avoid. If possible, there's no need of surgery. Okay, surgery is mainly always done for ruptured ectopic pregnancy. Okay, so when we have a ruptured ectopic, pregnancy, then we definitely go for immediate surgery after initial resuscitation of the patient and all that. Okay, again, a very, very useful. Match the column, all of you. Failure rate, in this column we have mentioned the different contraceptive method. Here we are referring the failure rate. Chalo, tell me the answer. Okay, yes, laparotomy will be preferred. Surgery, perfectly correct. Jimmy, correct. Excellent. So male condom has got a very, very high failure rate of 4 to 14. So 1D is there. 1D. So 1 is not A. So this is out. 1 is not B. So even this is out. Copper T, very, very low failure rate. Copper T, the failure rate is only how much? So say with this, clap if you feel happy with this one MCQ. We are discussing 5 MCQs. Copper T has a failure rate of 0.5 to 1.5%. So 2A. 2A. LNG-IUD, extremely low failure rate, one of the least failure rate, and it is 3C, 0.09 to only 0.1%. Yes, 3C. Okay, and diaphragm, 4B. Diaphragm has got very high failure rate, to be specific 18 to 28%. So please by heart this number, student. You'll remember me on the day of the exam, is my guarantee. So 4 is going with B. 4 is going with B. 4 is not E. Okay, 4 is clearly B. 4B, diaphragm can't be E so less. And DMPA injection is this. Yes, so 5E. Okay, 1D, 2A, yes. Anybody confusion? Second is the answer. Okay, 5 is not B. Okay, 5 is not B. Okay, 5 is not B. B itna high nahi hai. Okay, so 5 cannot go with B. So this is also wrong. And option 2, yes, perfectly correct. So 5 MCQs discussed in 1 minute. Absolutely high yield game going on. Male condom 4 to 14%. Copper T 0.5 to 1.5%, LNG IUD 0.09 to 0.1%, DMPA injection 0.1 to 0.4, diaphragm 18 to 28%. Okay. Yes. Now again a very, very important. We have a twin, some gadbad, daya, kuch to gadbad hai. Okay. CID investigation you have to do. Anybody? After twins delivery, husband is saying that one baby is his, but one baby is of the neighbor or whoever. Okay, then what is the diagnosis? Anybody? So remember, students, yes, very good. So I'll explain to you what is this. All of you got this, very likely to be coming in the exam, also the real life case also. If many of you have seen the new recently in the newspaper also, there's this one kind of a case where twins were born. How does this happen is basically in our PG books. There's a photo also. Twins are there, and one baby fair and one baby dark. Okay, so ek beta gora. We have nothing against the color, but one baby, ek gora, ek kala. Okay, so this we are not discriminating anybody, but that's how the picture is there in our PG books. That one boy is fair and white, and other is darkish in color and blackish in color. Okay, yes. So remember. Very good, Elizabeth Joshi. That is the way to remember that superfetation not possible in humans. Okay, why? Because what? It is not possible in humans. Okay, so please understand this. Yes, and therefore superfecundation is the answer. So what happens in superfecundation? Anybody? Two ovaries. Okay, two ovaries are released. Two ova. Okay, so in superfecundation, two ovaries. Okay, two ovaries are released in the same cycle. Okay, I am discussing superfecundation. Two ovaries are released in the same cycle, but fertilized by different acts of coitus. Fertilized by different acts of coitus, same or different partner. Of course, it's the same partner, no one will even come to know. But what happens is, let's say in the night, the wife has sex with the husband, and then egg and the sperm unite and one baby is conceived. And then the husband goes to office, and then the neighbor enters the movie. Okay, so then in the afternoon or morning there is sex with the neighbor, and therefore you can see two ovaries, same cycle but different acts. Okay, different acts and not necessarily same partner, even different partner. So this is absolute scenario. Let's say out of the twins, one baby is his and one baby is of the neighbor. So that is superfecundation. Superfetation means what? Anybody? Superfetation not possible in human, because superfetation not possible in humans because, sir, one egg and one sperm is already formed, and here the egg is released in different cycle. So that is not possible because, sir, superfetation रखेंगे fetus के ऊपर fetus. Okay, fetus के ऊपर fetus. Yes, animals में होता है, correct, mares and all that. So sir, one baby is already started to form. Egg and the sperm unite, one baby is already started to form, and then during pregnancy one more ovulation take place, and then the second baby. So it's like baby ke upar baby, difference of one cycle. Okay, so there are two different cycles. That is superfetation not possible even because in humans, once the patient conceives, the ovulation is suspended. During pregnancy you can't ovulate. Okay, so here fetation requires patient to ovulate during pregnancy. One baby has already started to form, and then there is again ovulation. So that is not possible, and then the second baby will get implanted. Okay, yes, different age will be seen. One baby will be 1 month bigger. So twins may one baby 4 months, another 3 months. One will be 5, one will be 6 like that. 1 month difference. So that is not possible. Okay, in humans. Yes, again, this is a repetition but slightly different way of asking the question. Recurrent abortion at 8 weeks, 11 weeks, and pre-eclampsia. What I wanted to tell you in this MCQ, can anybody tell me when does cervical incompetence cause abortion? Okay. So this is again when we are getting repeated abortions and severe preeclampsia, that also early onset. This is antiphospholipid antibody syndrome. Okay, in APLA syndrome, no beta, no Elizabeth. Okay, cervical incompetence. When will cervical incompetence cause abortion? Yes. No, Sam Newton, no. Okay, cervical incompetence will always cause abortion in the second trimester. This patient has abortion at 8 weeks, 11 weeks, so it is not possible in cervical incompetence. Very good. Medico, Payal Patel, Avni, Leah and Raju, all of you correct. So multiple first trimester abortion, severe onset preeclampsia या severe IUGR, all are features of antiphospholipid antibody syndrome. Cervical incompetence is always going to cause abortion in the second trimester. Okay, yes, APLA can happen in any trimester. You are correct, Jimmy. APLA can happen in late IUFD also. APLA can also cause in the third trimester. APLA can cause what? Sudden IUFD. Okay, remember this. Sudden IUFD can also happen with APLA. But APLA more likely to cause abortions in the first trimester and severe early onset preeclampsia and IUGR in the second and third. Okay, and IUFD in the third trimester. Okay, yes, yes. And TORCH can cause one abortion, but TORCH will not cause repeated abortion. And GDM can never cause. Okay, GDM will develop later on. So GDM does not cause abortion. Okay, yes. Simple but very, very important. Likely, if a 36 weeks pregnant lady is given indomethacin for management of polyhydramnios, what complication can she develop? Yes. Okay, sir. Indomethacin is used in management of polyhydramnios, and all of us know it will cause premature closure of ductus arteriosus. So this is very, very important. It does not cause VSD and ASD. Of course, the problem is because it's an NSAID, and therefore we don't give it at 36 weeks. Indomethacin can be used for polyhydramnios less than 34 weeks. Okay, before 34 weeks, yeah, 32 मेडिको 34 तक दे सकते. Okay, till 34 you can give, but here since it is given at 36 weeks, there's a problem. Yes. Okay, yes, again very, very important, when the patient has a lactational amenorrhea and directly she has conceived, what do we do to calculate the gestational age? Yes, excellent. What is this called, anybody? What is this called? When you measure crown, and which trimester do I measure crown rump length? In the first trimester. Okay, in the, because here LMP, she didn't get her LMP only, and again UPT is not very good, and abdominal circumference is mainly for IUGR in the third trimester. Crown rump length is measured in the first trimester. This, my dear student, is called dating scan. Now, dating scan is not when you take your girlfriend on a date and do her sonography. We get such answers in Viva. Okay, sir, during dating period, boyfriend will do girlfriend scan, girlfriend will do boyfriend scan. That is not dating scan. Dating scan is to date the pregnancy. And to date the pregnancy, perfectly correct, we use crown rump length. CRL is used in the first trimester, and that is used where we will get most accurately, yeah, 6, 7, 8, anything in the first week. Okay, we will use the dating scan, specifically crown rump length. 6, okay, but 6, 7, 8, 9, anywhere we have done the scan, and then you can give patient the due date, that is the USGDD, because that is the why we use the first trimester scan, because it's the most accurate. Okay, note it down. Why is it the most accurate? Because, sir, yeah, UPT positive means HCG is positive. Correct, Jimmy. Okay, Jimmy, when they say urine pregnancy test is positive, urine pregnancy test mein what will be coming? Urinary HCG in the urine, and in the blood also it will be positive. Okay, so when you say UPT positive, perfectly correct, urinary HCG. Urinary HCG is positive. Okay. Okay. Yes. So this is the most accurate for dating the pregnancy, and it could be anything in the first trimester, 6, 7, 8, 9. Okay. So keep in mind that this is used. And abdominal girth is used in the third trimester as a marker for IUGR. Again, very important, all of you. Known case of hypertension, preconceptional counseling, she is coming to us. Which of the drugs should be avoided? Which of the drugs should be avoided? So, labetalol can be used, nifedipine also very safe, and yes, all of you, ACE inhibitors absolutely contraindicated during pregnancy. Why? ACE inhibitors will do what? Which organ? ACE inhibitors will act on fetal, which organ? Yeah, exactly what? ACE inhibitors will act on fetal kidneys. Okay, ACE inhibitors will act on fetal kidneys, and they will act on fetal kidneys and can cause severe oligohydramnios. And therefore, yes, ACE inhibitors as well as your AR. Okay, so your angiotensin receptor blockers, both, yes, kidney problem and renal problem and severe oligo and all the other complications. Okay, so please keep this in mind. Yes, kidney, just what that was what you remember. Okay, yes. Yes, again, very important MCQ, again a clinical case. BP, what is the diagnosis? BP 150, 110, and there is associated proteinuria. So what is the diagnosis over here? Anybody? It is a case of, yes. Anybody? Yes, excellent all of you. Excellent all of you. Preeclampsia is the diagnosis because there is increase in blood pressure along with proteinuria. All of the following complications are except chalo. What, you are not reading the question. Except with hypertension, what can happen? Help can happen, yes. The question is all are expected complication except. Yes. अरे बेटा डॉक्टर AM and Arakdeep and Ajmal, yes, if a patient is having preeclampsia, can she develop eclampsia? Of course, sir. Can there be abruption? Of course, sir. Can there be HELP syndrome? What is HELP syndrome full form? Ha, Payal Patel, have correct have you? Ha, okay, correct. Okay, sir, all of the following complications except. Okay, so hemolysis, yeah, liver function, renal function is normal as of now, that is okay. The question is that all can develop except hemolysis, elevated liver enzyme, low platelets. Yes, normal abhi, but all are expected except macrosomy. Macrosomy is a big baby, chota elephant, chota hathi. Macrosomy you get in diabetes. Preeclampsia will always lead to IUGR. Okay, is this understood to all of you? Yes, the question is right now renal function, liver function is normal. Agreed. That's a trick thing. All are the expected complication of this condition. Okay, Is it clear? So hemolysis, elevated liver enzyme, low platelets can develop, and therefore macrosomy is the answer, because a preeclampsia always will lead to development of IUGR. Beta, abruption is a very, very important. Except what? Okay. Yeah. Rovastatin, yes, because of severe vasospasm. There's a severe vasospasm. So abruption is a very, very known and very, very common complication of hypertension. Okay. Okay, Dr. Rovastatin, abruption, definitely keep in mind, abruption is one of the very common complication of preeclampsia. Okay. In fact, for abruption, the important risk is your preeclampsia and past history. These are the two things. Yes. So all of you, please don't make mistakes in such MCQs, because there's going to be a problem if you just don't read properly. Yes. Again, very, very popular one-liner, but yes, use of OC pills are helpful for all of the following except. Again, except. Okay, that's why I'm underlining the word except for all of you. OC pill decreases all except. Yes. Excellent. So point number 1, which cancer OC pill decreases? Which cancer OC pill will decrease? Clap if you feel happy. Remember CEO. CEO means colon. Colon. E endometrium, O ovarian. So ovarian malignancy is going to decrease. Yes, colon cancer, endometrium is going to decrease. I explained to you in today's lecture only cervical mucus will become thick. So PID episodes will become lesser. So ectopic is also going to be lesser, and PID is also going to be lesser, and PMS is what? Premenstrual symptoms or premenstrual syndrome, where there is patient gets bloating and mood swings, irritability, all that happens in ovulatory cycle. So OC pills is going to help in PMS also. Hepatic adenoma is going to increase. Hepatic adenoma is going to increase with our OC pills. Okay, slight marginal increase is there. Okay, there is a slight marginal increase in hepatic adenoma, but that is after prolonged use. Okay, so I hope all of you will be remembering all this in the exams for sure. Treatment for Asherman syndrome. Anybody? Again, very, very important MCQ, surely going to be asked in the exam. What is Asherman syndrome? Asherman syndrome is presence of intrauterine adhesions. And therefore, we are not going to do laparoscopic adhesiolysis. Laparoscopy, no role. Yes, no Nitin, no Megha. Okay, DNC will not help. In fact, excessive DNC can cause. And all of the above nahi hai, and only LNG nahi hai. Yes, we will put in a telescope. We will put in a telescope through the cervix and through the hysteroscopy guidance, because everything is inside the cavity. So hysteroscopy will be done, and hysteroscopic adhesiolysis, PYQ 100% repeat, my guarantee. Okay, hysteroscopy will be done, and with the hysteroscopy you will go and you will break. See how I'm cutting the, can you see the adhesions being cut? Can you see the adhesion one by one being cut like this, like this, like this, like this? Hysteroscopy surgery will be done. hysteroscopic adhesiolysis will be done for Asherman's syndrome because it is intrauterine adhesion. Okay, it is intrauterine adhesion. Okay, laparoscopic adhesiolysis is for which adhesions? Anybody? Okay, yes. Okay, so laparoscopic adhesiolysis is done for which condition? So laparoscopic adhesiolysis will be done if there are adhesions between the, suppose, the tube and the ovary. Okay, not okay. So there is adhesions between the tube and the ovary, or there are any other adhesions, then you can do laparoscopy. Okay, yes, endometriosis and all that. Okay, yes, laparoscopy is done for pelvic adhesions. If there is adhesions in the pelvic area or between the tube and the ovary, or there are pelvic adhesions. No, Fitzhugh Curtis you just make. Okay, no multi. We just Fitzhugh Curtis you diagnose with laparoscopy, but you don't have to break the adhesions. Yes. Okay. Yes, if any pelvic adhesions are there, that you break with your this. Okay. Yes. Now again, clap if what is the clinical case? Clinical difficult virgin MCQ. All of you by now know my terminology virgin MCQ. Not asked till now, will come in the future exams. Chalo, what is the diagnosis? Anybody? The diagnosis is patient has infertility, patient has dyspareunia and dysmenorrhea. That means patient is having DID. What is DID? Yes, Sakshi Patel, excellent. DID is my dyspareunia, dysmenorrhea, infertility. This is the symptoms for endometriosis. Okay, and in endometriosis, I am not going to see subserosal fibroid. Why should I see Asherman syndrome? In endometriosis, perfectly correct. Yes, dance India dance, that's my mnemonic. Okay, clap if you feel happy. We are going to get chocolate cyst and adhesions in the pouch of Douglas. Chocolate cyst is a feature of endometriosis. Adhesions in the pouch of Douglas is also the feature of endometriosis. Laparoscopy findings most likely in this patient. They have asked you ulta. In a patient of endometriosis, what is the most likely laparoscopy finding? We have to remember chocolate cyst and adhesions in the pouch of Douglas. Along with you also get red lesion, blue lesion, all that you get. Okay. So it's very difficult MCQ, but keep in mind DID symptoms. Okay. Yes. Again, very, very important. 47-year-old, menorrhagia for 3 months. The next line of management is surely coming in the exam. Anybody? Yes. Now, whenever I have, please underline the word 47 3 times. Okay, 47 3 times. And the common mistake which students make is they directly mark hysterectomy. Wrong. Hysterectomy never directly. Why never directly go for hysterectomy? Try to save the uterus. Okay, why you try to save the uterus? So never ever directly go for hysterectomy. Yes, please keep in mind point number 1. This 2 centimeter anterior wall fibroid is just given to confuse you, to आपको उल्लू बनाने के लिए दिया है. Point number 1, a 2 centimeter anterior wall fibroid, 2 centimeter anterior wall fibroid, nor on it, will not cause menorrhagia. Okay, so again, no point doing myomectomy. Myomectomy is 5, 6, 7, 8 centimeter fibroid in young patients, or if the fibroid is within the cavity of the uterus. Yes, if the fibroid, they tell you, is projecting into the cavity of the uterus, then definitely I will remove that fibroid. Are you understanding, all of you? A 2 centimeter anterior wall fibroid is just an incidental finding. It is not going to cause menorrhagia in the patient. Okay, and any patient 47 means she is perimenopausal. She is a perimenopausal patient, and therefore what has to be done? A DNC has to be done. Why? Because you need to rule out any patient who is perimenopausal. Of course, all the details I'll explain to you in the actual lectures. Okay, yes, medical management ke pehle also, Elizabeth, first you need to rule out endometrial hyperplasia, endometrial cancer, isn't it? Because if it is cancer, then you can't give medical management. Okay, Elizabeth? Okay, yes. So perimenopausal patient, very good, Sakshi. That's, sir, first you will rule out endometrial hyperplasia, endometrial cancer in any patient who is perimenopausal, and this is possible only by histopathological examination of the endometrium. HPE is mandatory, and therefore DNC will be done first. Do not directly do hysterectomy. Yes, if the report is cancer, then you can, because which hysterectomy will you do? Simple, radical, what hysterectomy? And myomectomy, again, no role. 2 centimeter fibroid, no point removing that 2 centimeter fibroid. Progesterone therapy can be given after DNC. After DNC, suppose there is no cancer, then progesterone definitely you can try to save the uterus, and then only hysterectomy is only last resort. Okay, only as a last resort you try to do hysterectomy. Is this understood to all of you? Yes, only as the last option you do hysterectomy. So DNC should be done because HPE is mandatory. Write down these words. HPE mandatory. HPE mandatory. Okay, compulsory in any patient who is in the perimenopausal age group. Yes, again a very important, surely coming. Yeah, then hysterectomy beta can be anything. Any hysterectomy can be done. Laparoscopic, or that's later on you can. Yes, all are used for screening in the second trimester for aneuploidy, matlab trisomy 21. Again, except is the word. Okay. Beta Mega, simple or radical will depend on your diagnosis. If it is only hyperplasia, Mega, I will do simple. If it's cancer, I will do radical. Okay. So, yes. Okay. What is the triple marker and the quadruple marker test? HCG, alpha fetoprotein, unconjugated estriol. Unconjugated. Yeah, beta, if it is 5 centimeter, no, 5 centimeter very big, beta, MGB. Dr. MGB, what you are saying is if in a post-menopausal lady, it should be less than 5 millimeter. Okay, MGB, Dr. MGB, less than 5 millimeter always in a post-menopausal lady. Endometrial thickness. Yes. So anybody? Yes, Doshi. HCG, alpha fetoprotein, unconjugated estriol. These three are my triple marker test. And inhibin A is a part of the quadruple marker test? And can anybody tell me which trimester I do triple marker and quadruple marker test? Triple marker, quadruple marker is done in which trimester? Yes, Medico, very good. So, sir, triple marker, quadruple marker, both the triple marker test and quadruple marker test are done in the second trimester. Perfectly correct. And the answer is PAP A. Why? Because sir, PAP A is done in the first trimester, T1. Okay, in the first trimester, I do PAP A testing. Okay, is this understood to all of you? Yes. So HCG, all the triple marker test and quadruple marker test are done in the second trimester, and PAP A is a part of my dual marker test, which is done double marker test. Okay, so that is your, because again, except, all of you please read. Yes, please read the word except. PAP A, pregnancy associated plasma protein A. So don't uh, make a mistake in this, in the MCQ, in the exam. Okay, so yes, again, anybody, very very popular. Okay, what is this device, what is the device, and what is it having, and total how much having? Okay, so yes, we have already shown you the image. This is LNG20 Myrina, brand name LNG IUD, also called as LNG20, not because it contains 20 milligram. Yes, Myrina is the brand name, all of you correct, and it contains 52 milligrams of LNG. Then why I call it, so that's the answer, why I call it LNG20, because 20 microgram is released per day. Okay, and go back and check today class, only I showed you all the benefits and all the advantages. Okay, so LNG20, because 20 microgram per day, this is the total quantity. That's 52 milligram is the total quantity. So I hope you don't make a mistake in all this. Very very common MCQ, very popular. The most common anomaly in the baby of the diabetic mother. Most common anomaly in the baby of the diabetic mother. Yes. So anencephaly is my neural tube defect. That is the second most common. VSD. VSD is the most common. Most common. Okay. All those who are telling me option A, please understand the question is most common. Okay. Sacral agenesis is the most specific. There's a difference, I hope you understand, between specific and common. Most specific anomaly. Most specific anomaly in the baby of the diabetic mother is sacral agenesis or caudal regression syndrome. Okay, not the most common. Most common is VSD. Yes, ventricular septal defect is the most common. Most specific is sacral agenesis. So please don't make a mistake in all this. Okay, so just a second, all of you. Yes, this is a this very very in. Yes, anybody? So yes, which is the, coming back to our level of the methotrexate, very, which is an indication for surgical management. Again a PYQ. So I've told you the criteria, that sir, which is a surgical management, not patient wants to continue pregnant. You can't continue ectopic. Okay, unruptured ectopic we prefer methotrexate. Similarly, if the HCG levels are less than 1000, again we prefer methotrexate. Yes, that's sir, for methotrexate the sac size should be less than 4 centimeter. If the sac size is more than 4 centimeter, we should go for surgical management. Okay, we should go for surgical management, which is very important. Okay, so just question, yes. Okay, just a second, all of you, this is very 1 second. Yes, somebody want like a level and this, yes. Anybody, what is this picture showing you? What is this picture showing you? Yes, this is a strawberry cervix, multiple pinpoint hemorrhages. Strawberry cervix is there where you see all these punctate hemorrhages everywhere, and this is with trichomoniasis. Okay, greenish yellow discharge, and again metronidazole is the drug of choice. Okay, now somebody asked me about the Liker levels. That also I am here. Tobacco juice liker, tobacco juice color liker, and the liker levels. Anybody, when do you think is the liker level maximum? Yeah, strawberry cervix, greenish discharge, all of you correct. Yes, yes. So tobacco juice, you don't know, no, not in heavy smokers. Okay, if the mother is smoking, the liker will not become very trick. Okay, no. Yes, so please understand. And okay, so remember this very important table, and thank me. Okay, so maximum liker 36 weeks. Okay, 36 weeks the liker is maximum. Just somebody wanted to ask me this. So around 1000 ml, 36 weeks, please mark as the answer. 40 weeks it is going to be lesser by 800, and as the level will become postdatism, the liker will of course decrease. And perfectly correct, tobacco juice is seen in IUFD. Tobacco juice liker is seen when the baby dies. Again, these were old questions, very rarely I'm seeing it correct. RH incompatibly. Okay, golden color, golden color in RH incompatibility. Okay, so tobacco juice IUFD, blood stain of course is abruption. Okay, so just a second, all of you, yeah, so this is what I wanted to show all of you. This is which view? Anybody, this is hysteroscopy or laparoscopy? This I am seeing the uterus, this we are seeing the ovary, fallopian tube. So which is this view? Perfectly correct, all of you. This is a laparoscopy view where we will see the uterus from outer surface. Okay, so you can't see what is inside the uterus, and therefore you can't find out whether it is inside the uterus septum or not. That requires your hysteroscopy to be done. Okay, yes, just give me a minute. Yes, now this is true about Turner's syndrome, all except hysteroscopy. We will see the inside of the uterus. Yes. In Turner's syndrome, all except. So Turner syndrome, do you have primary amenorrhea? Of course, sir. It is the most common cause for primary amenorrhea. Turner syndrome, do you have streak ovaries? Yes, sir. Streak ovaries is also there. But remember, student, Turner syndrome में uterus होता है. Okay, chintu uterus, chota uterus, but it is not absent uterus. Absent uterus, I already told you today. Go back and see the first part of the video. Okay, the Turner syndrome, the uterus is not absent. In Turner syndrome, uterus is chintu, hypoplastic. Okay, hypoplastic or chintu uterus, but hypoplastic uterus, yes, it is present. Uterus is present. It is not absent uterus. Absent uterus I get only in RMKH and androgen insensitivity syndrome. Okay, so when you will hear my actual lectures, all of you will become expert, is my guarantee. And students will, I will teach in such a way that you will not only understand the concepts, you will remember lifelong, is my guarantee. Yes. Okay, just a second, all of you, just 1 second. Okay, so I want to show you one more important. Yes, can anybody tell me this instrument? Can anybody tell me this instrument? A patient underwent a 3 times procedure with this instrument. Yes. What is this instrument? What is this instrument? Anybody? This is a curette. Yes, this is a curette, uterine curette. This is a uterine curette which we use for DNC, dilatation and curettage. And if you have, no, this is not an anterior vaginal retractor, no beta. Okay, anterior vaginal retractor is a big thing. Okay, this is a small curette. Okay, AV wall retractor will have this bigger end. Okay, AV wall retractor, very confusing, you are correct, but this will not be so small. In anterior vaginal wall retractor, the thing is that this part will be very big. Okay, so AV wall retractor will be like this big part, and then like this, and then it has got it at an angle. Okay, so that is a big thing. Okay, no, this is a curette because the ends are small, one end sharp, and it's a uterine curette. And in the curette, if she has undergone 3 times curettage, then the likely complication is Asherman syndrome. Asherman syndrome, and therefore not endometriosis, which is the most likely complication. Most likely क्या होता है? Most likely, yes, infertility, not all. Menorrhagia नहीं होगा. In fact, menses, what happens to the menses? Menses become scanty. In your hypomenorrhea, in your Asherman syndrome, the menses become scanty. Yes, because of intrauterine adhesions. Because of intrauterine adhesion, this is again a clinical case, multiple DNC, Asherman syndrome, infertility will be the patient's diagnosis, or infertility with the complication. Yes, again, this is very important, which is not true for trisomy 21. Not true for trisomy 21. Yes, Vikram, multiple friends. Okay, so increase in NT, today only I showed you that certain Down syndrome, increase in NT will happen. PAP-A can also decrease, and alpha fetoprotein is also going to decrease. Very good, all of you. That sir, if the baby is having trisomy 21, in my double marker, triple marker, quadruple marker, all of them, the HCG levels are going to be increasing. H levels are higher than normal, that is the answer. Okay, HCG is going to increase. Yes, 19-year-old, again a clinical case for all of us. 19-year-old girl comes with prolonged bleeding, heavy periods during menses, which is not usually advised. Which is not usually advised. Yes, inhibin also increases. Very good, Mangesh. Yes, logic. Very simple. Okay, so please understand this, that whenever we have a young girl, 17, 18, 19, let it be unmarried, that is okay. In a young girl, the causes of menorrhagia are my immature HPO axis, and it could also be bleeding disorders like von Willebrand, ITP. So bleeding time, clotting time, PT, APTT, prothrombin time, definitely coagulation profile and platelet count we should do. CBC and platelet count I should do, which is not usually advised is the answer. Yes, okay, which is not usually advised the answer. Just a second, all of you. Okay, just give me exactly 10 seconds. Yes, okay, so okay, so coagulation profile, BTCT we will do. Definitely ultrasonography we should do. Ultrasonography stress to make sure that everything is clear, and please rule out pregnancy. Unmarried girl, don't get fooled. Okay, whenever the girl is there, why I need to rule out pregnancy? Anybody? Why we need to rule out pregnancy? Because sir, pregnancy complication, please understand, pregnancy will not cause menorrhagia, but pregnancy complications, sir, it could be threatened abortion, she could be incomplete abortion, it could have been ectopic pregnancy. So you need to rule out pregnancy first whenever the patient comes with heavy irregular bleeding, because pregnancy complications like incomplete abortion and inevitable abortion may also cause prolonged heavy bleeding, and ectopic also. Yes, hysteroscopy and biopsy is the least expected. You don't do this in a 18-20-year-old girl, but if the question is 45-year-old lady, then I will first do endometrial biopsy. Okay, so hysteroscopy biopsy, in which age group do we do? Yes, the hysteroscopy biopsy is the answer, because that I would want to do in which age group? Definitely hysteroscopy biopsy I would want to do in my perimenopausal patients, which today I just explained to you the MCQ, that if the patient is perimenopausal, then hysteroscopy biopsy we do. There's no point doing a hysteroscopy biopsy in a young 19-year-old girl. Okay, adnexia, again ectopic, ultrasound uterus tour, again rule out pregnancy complication, urine test, and yeah, peri and post both. Okay, yes, a new style of asking question. 4 options are given, and 1, 2, 3, 4 statements are given regarding uterine leiomyoma. Which of the above statements are correct? Yes, anybody? Which of the following statements are correct regarding fibroids? So it's a simple question that, sir, do I get fibroids more commonly between 35 to 45 years? Yes, sir. 35 to 40 is correct. That's the age group, 30 plus. Is it more common in nulliparous patients? Yes, nulliparous patients, infertile patients. Yes, the fibroid is more common. And yes, Dr. Sky, very good. And display when I give GnRH analogs. Okay, when you give GnRH analogs, the fibroids are going to shrink in size, but it's a temporary shrinkage. Okay, and very important, all fibroids do not require or do not require treatment. Which of the following statements regarding this? Which are correct statements? Which are correct statement? Common sense, sir. All of you look on the board. Sir, suppose this is the uterus and there is a chintu 2 centimeter fibroid outside the uterus. I get so many students call me. So many students come to visit me in my clinic in Mumbai, or so many students call me, okay, sir, my mother is having 2 centimeter fibroid outside the uterus. Doctor is telling remove the uterus. I said no need. Okay. So all fibroids do not require treatment. That is also correct. Yes. So 1, 2, 3, 4. Clap if you like this new style of MCQ. Okay. So all statements are correct. Prevalence 35 to 45 years. Nulliparous patients. All fibroids do not require treatment is absolutely correct statement. And display reversible shrinkage with GnRH analogs is also absolutely correct. Okay. Yes. So and the last question, probably all of the following are known complications of fibroid in pregnancy except. Okay. Yes. Okay. But I don't sing. I can't sing, beta Jimmy. Very sorry. I am not a good singer at all. Inside the fibroid, intramural, no, then it depends, but it depends on the age and everything. Okay, yes. So when I have a fibroid in pregnancy together, can the fibroid cause abortions? Yes, sir. Fibroid can cause abortions. Fibroid can cause preterm labor also, and very good, after delivery the uterus will not contract properly. If there are multiple fibroids here, then even PPH can happen. Common sense. Malformation, just because a fibroid is there, just because a fibroid is there, just because a fibroid is there, okay, just because a fibroid is there, fibroid will not cause preterm, fibroid will not cause malformation. Preterm labor also, fibroid cannot cause malformation in the baby. Please keep this in mind, very important. Okay, fibroid cannot cause a malformation in the baby. Just because a fibroid is there, fibroid will not cause the baby lung to be damaged or kidney absent or heart problem and all that. Malformation, all of us know, are some genetic problem in the baby, or folic acid deficiency, neural tube defect. Malformation has multiple etiologies, but fibroid cannot cause malformation in the baby. Okay, so I wish, or I hope all of you had a No, DNC is never a this beta. Okay, DNC is never a treatment for fibroids. Not how many time maximum DNC can be. Okay, but oxytocin, rovastatin and oxytocin is contraindicated in obstructed labor patients. Okay, so last time I wish all of you a very best of luck for the examination, and I want all of you, yes, all of the following are etiology for breech except the last question. For breech, oligohydramnios and polyhydramnios, both less liker and more liker, both can cause breech, and hydrocephalus babies also there can be breech. And anencephaly, remember, is more likely to be associated with face presentation. Okay, face presentation. So point number one, two things. Point number one, okay, yeah, I will send the annotation bit. Okay, this Arisha. Okay, so OG Guru app is my app which has just been launched. And OG Guru app, please, all of you, like how you have heard my 3 to 4 hours class, absolutely super lectures you are going to get, and you will love the concept, is my guarantee. And please install the app. Also give the free mock test, all of you, on the OG Guru app. And also do come in for the beta liver malpresentations are very common. Okay, and do come to the app, and directly I'm going to give you guidance, mentorship, doubt solving, all is going to be available. And as a last request, I request one more time, all of you, do subscribe to the OB, this my YouTube channel also, and on Telegram also you can be in touch with me. You can click a screenshot of this and you can this. Okay, and one more thing which I wanted to inform all of you was that, yes, I think this is just one. Yeah, so uh, yeah, 15th of January. Okay, just a thing. Okay, 15th. Yeah, so 15th of January onwards in Delhi, the new batch is starting. Okay, yeah, to need PG also, absolutely everything. Okay, so we will definitely, when you install the app and you be in touch with me regular, I'll be there to guide you. I'll be there to help you out how to study, how to prepare. Click a screenshot of this image, and definitely all of you will get very good marks in OBGY, is my guarantee. 15th of January, a new batch is starting at the Next Learning Center. So all of you, those who are in Delhi, can enroll for the batch. Yeah, thank you very much. Okay. Yes. Okay. I wish all of you best of luck. Shower the love. Share this video maximum with all your friends. Do smash the subscribe button, like button, and regularly be in touch with me over the phone and WhatsApp. And wishing you all the best. And these questions are going to be coming in your FMG exam and also in your NEET PG. And you will remember me on the day of the exam, is my guarantee. And when you master the videos from the app, all of you will get the maximum possible marks in OBGY, is my guarantee. My mission is to make your OBGY very easy, and hashtag crystal clear concept. Best of luck, all of you, and do well in all your exams. And do give the mock test also on the OG Guru app, and subscribe to the YouTube channel. And the, yeah, there's a Telegram link button. Telegram, click a photo quickly. This is for the Telegram only. Okay, I'll just this photo is there. Thank you all of you. Thank you very much. Yeah, you can just scan it. You can directly scan it. And this is the Telegram channel link also. Okay, so in the beginning of the video also, just you can go to the starting area. It's my face is slightly getting hidden, hiding the link over here. But in the beginning of the video also, I had sent this link was given. You can just take a screenshot and join the YouTube as well as this channel. Okay, and 15 January in the NLC Center, the coaching is starting. That is in Delhi, online offline classes. So all of you can also join in, and do subscribe to the OG Guru app. Best of luck for your exams, and all of you will do very well, is my guarantee. Yes. Thank you. Thank you.